and certainly have made it a huge success. We can't be remiss in forgetting that the Alumni Association of the Sanchetti Institute, as well as the Sanchetti Hospital, have been supporters of this and have been founders of this for many, many years. So we thank them. We also take an opportunity, if we could, just to thank our partners in this. So OrthoTV has been live streaming this. Let me remind you again that Ortho Evidence will provide all of you who are members and who have attended full free access for 1 year. So we'll make sure that we look out for those emails as we move forward. We're also thankful for the IACON and the POA, as well as McMaster, for this partnership. But let's begin. We have a very, very interesting packed session of lower extremity. We're going to move from the hip and slowly work our way down, covering all of the critical topics and discussing evidence and surgical technique. And who better than to help us work through this wonderful agenda than our own moderator for this evening, Dr. Chetan Pradhan. Chetan, take it away.
Thank you, Mohit, for those opening remarks. I welcome all the delegates and the faculty for the second day of this Pune Trauma Operative course on behalf of the Alumni Association, Pune Orthopaedic Society, Ortho Evidence, the McMaster University, and various other people who have put it together. So we start with the lower limb, and to start with the unsolved fracture, we have none other than Professor G.S. Kulkarni, who obviously needs no introduction in this country and abroad. Dr. G.S. Kulkarni from Miras. He is, in fact, compiling a book on the intracapsular fracture neck femur, and I would now invite Kulkarni sir to start his talk on intracapsular fractures of the neck femur. Sir, you can share your screen.
Yeah. Thank you, Chetan, for giving me an opportunity to present my research work on the treatment of fracture neck femur by a new technique. We call it GSKT system. Now, how the fracture neck femur heals? When we use any implant for fracture neck femur, fragments are compressed. That means essentially healing is by compression method. That is primary healing by absolute stability. So implants allow sliding movement. Mobility is contrary to EVO principles of primary healing by absolute stability. So when we use compression fracture or compression method for fracture humerus or any other bone treated by compression plating, do you allow mobility of the fragments? No. Then why violate the principle only for fracture neck femur? Is sliding movement the cause of non-union and avian? We believe yes. Primary healing and mobility. After compression, there should be no mobility, not even micromotion, to protect the lag effect. There is also neovascular ingrowth from the distal fragment, which has abundant blood supply and creeping substitution. Both these processes are microscopic and both do not tolerate any mobility, not even micromotion. As we can't insert a protection plate, the other methods are used to provide absolute stability, such as the GSKT system, antero-inferior plate, and locking plate. Sliding mechanism causes excessive collapse, which leads to healing problems such as non-union avian. Parker injury 2010. Why sliding movement is the cause of non-union and avian? We will have some biomechanical insight. See this, when we are standing on one leg, there are tremendous forces acting on the head of the femur, 3 times the body weight, and this force is at an angle of 16 degrees. This is important to note. There are 3 situations here. One is the transverse fracture, another is the vertical fracture, and the third one is a oblique fracture. Now in the first picture, the weight is acting as a compressive forces. So there is 100% compressive force and 0 shearing force. This occurs in Powell type 1. And in a vertical fracture, when the weight is put, it slides down, causing shearing due to shearing forces. So there are 100% shearing forces and 0% compressive forces, which occurs in Powell's type 3. And in this situation, there is a combination of compressive forces and shearing forces. So in a clinical situation, a fracture like this, with a Powell's angle of 16 degrees, and the forces also are 16 degrees. When such a force occurs, the force direction is at right angles to the fracture side. Therefore, the forces are 100% compressive and there is 0 shearing forces in the clinical situation. Now, this is a fracture which is more than 90 degrees Powell's angle. Such a situation does occur in our city. We have a few cases. I will show you one case. And this is 106 degrees Powell's angle. And the force acting is almost parallel to the fracture line. 100% shearing forces and 0% compressive forces. See, this is parallel to each other. Now, I have done a theoretical graph of Powell's angle and its approximate relation to compressive and shearing forces. Take this example in which there is 16 degrees of Powell's angle, there is 100% compressive forces and 0 shearing forces. On the other hand, if you take the other situation where there is 106 degrees of Powell's angle, there is 0 compression force and 100% shearing force. And in between from here to here, there is a combination of shearing forces and compressive forces. At 61 degrees, the forces are 50% each. So shearing force is the cause of non-union and AVN. What is the evidence? The evidence is, the robust evidence is valgus osteotomy for non-union. Despite 1 year of non-union of fracture neck femur, with lot of fibrous tissue between the fragments, absorption of bony ends, and a large gap, union rate is 94% and AVN is 10%. So here the shearing forces are converted into compressive forces. A corollary to that is compressive force reduces the shearing force. So this is the example that I was telling you, that more than 90 degrees of example. Here you can see there is a fracture 90 degrees. And in this situation, we just made 3 compressive lag screws. So this 3 lag screws nullified the shearing forces and the fracture united nicely at 4 months. He also had a shaft fracture, which also united. Now I have some unanswered questions for non-union. And if Mohit can answer some of these questions, I will be very happy. Valgus osteotomy, union rate is 90%, 90 to 96%. Various studies have shown this. How the non-union heals in after the valgus osteotomy? Is it by creeping substitution, or is it healing by continuous compression during the post-operative period? Again, some of the answers also unanswered for AVN. After valgus osteotomy, AVN rate is 6 to 15%, almost similar to fresh fractures treated by DHS or 3 screws. Now the questions are, how the head is revascularized after valgus osteotomy? Is it by new vascular ingrowth, or is it by retained blood vessels especially the inferior retinacular artery or the ligamentum teres blood vessel, or is it recanalization of the blood vessels? Another question is why AVN occurs in undisplaced fractures where there is no damage to the any blood vessels. The literature is sparse. We feel that both retained blood vessels and ingrowth from the distal end work to revascularize the femoral head. This is a very important issue because we need to preserve the blood vessels by absolute stability. Now, Zhao has done a lot of work, research work on vasculature of the head of the femur. He has shown by injection method that there is a dome of vascularity by the epiphyseal vessels, and this dome is so good that in a normal head there is abundant vascularity. This is the wet bridge ligament, of which I will tell you next slide. So inferior retinacular artery is protected in the wet bridge ligament. This is the wet bridge ligament, and this is the inferior retinacular artery. This inferior retinacular artery is away from the bone, 1.6 millimeter here and more here. So this is protected by the wet bridge ligament during injury. And this is an important, retinacular vessel is very important for revascularization of fracture neck femur. After a long time also there is a retained vessel, the vessel is retained. So there are many articles on this, Boroya, Putman, and many others. So revascularization of the head was studied by Starmetio. He studied 112 cases of arthroplasty for fracture neck femur. At surgery, he injected dye and studied the vascularity of the head, especially the retinacular vessels. And his conclusions were post-operative, posterior retinacular artery present in 100% of the cases of Gardner 1, 2, and 3, and 95% was present in Gardner 4. They suggested that fixation rather than arthroplasty for fracture neck femur. So vascular damage may not be the main cause of non-union and AVN. Mohit Bhandari has made a very good, very important statement in one of his papers on hip preservation. And this goes like this. For hip fracture, it's the same way. Fixation retaining the natural anatomy of the hip was such an important principle decades ago. However, popularization of the hip replacement led a pendulum swing away from fixation of the fracture neck femur. I think the pendulum is once again swinging back to hip preservation. That means fixation should be done in most of the cases. This is a very important message for the whole world, and I feel the whole world should follow this. A few years back in our institution, a patient, 60 years old, fracture neck femur, bipolar or THR, total hip replacement. That is amputation of the head. However, this for the last few years, we are now changing and doing more and more fixation of elderly people, seniors more than 60, with good results. For healing of fracture neck femur without complications, the mantra is to optimize compressive forces, minimize shearing forces, and absolute stability during the post-operative period. This is probably the solution to the unsolved fracture. But how to achieve this mantra? 1, anatomic reduction. 2, choice and placement of implant. 3, by inserting lag screws at right angles to the fracture line for optimum compression and to minimize shearing forces. The methods to provide absolute stability. Now, this is the Gottfried technique of reduction. What he does is He puts a sling around the thigh as high as possible and gives traction distally and laterally to disimpact the fragment. As you see in this case here, there is disinfection has occurred, and then gentle longitudinal traction, internal rotation, adduction. He adducts for 45 degrees, but we feel that 20 degrees is enough. So this is, and then the step 5 is release both the tractions, the sling and the longitudinal traction, and you will get the excellent result in both AP and lateral views. What are the problems of DHS and 3 cancellous screws, the 2 commonly used implants? Displacement after fixation of 3 cancellous screws occurs in 30% due to inadequate purchase on the lateral cortex. Forces on the head tilt the head into varus and leads to failure. Lateral plate improves stability. This is a very important advancement according to M.J. Parker. Faith trial, I think Mohit is the chairman of this multinational, international trial. They studied collapse of the head in patient 1079, final sample was 350. Their conclusion was 33% of the cases had collapse of the head 5 to 10 millimeters, which results in functional disability. GOT 2009. Problems for both DHS and 3 cancellous screws. Large number of meta-analysis, RCTs and papers show that sliding mechanism causes excessive collapse, leads to healing problems, non-union and avian. Neck sharpening changes the biomechanics of the hip, and reoperation rate is 20 to 30%, which is unacceptable. Why 3 cancellous screws on the lateral, inadequate purchase and instability? When we insert a lag screws, we create a hole, and there is a gap between the shaft of the screw and the cortex, and this gap goes on increasing because of the thin cortex, and these are the lever arms, and then toggling occurs due to the gap. The gap causes the toggling of screws and 30% displacement. So the solution to that is an angle stable implant. Plate and sleeve causes lever arm. The sleeve has 3 functions. One, sleeve closes the gap between the cortex and the shaft of the screw. Fulcrum is medialized, and plate and sleeve prevent toggling and stabilize the lateral wall. This is the GSKT system based on truss and triangle principle to provide compression and absolute stability. What is this triangle business? The strength and mystery of triangles, biomechanics of triangle construct for GSKT system. Now, when force is applied to a triangle with hinged corners, 3 rods, there is no movement. A similar 4-sided square is easily moved. But if it is converted into triangles, then it does not move. The same thing happens with 6 rods. When force is applied, it moves, but when it is converted into triangles, it does not move. Now, the huge ball of Disney on principle of strength and triangle. See, these are all triangles. Huge buildings are constructed on triangle principles. The triangle construct is an engineering marvel. Can it be applied to ortho implants? Yes. Liver et al. Studied cadaveric studies on 5 constructs, and on the proximal humerus, they found the triangle construct was the strongest. So we decided to do the same principle for fracture neck of femur using the plate and screws as triangle, and this is the we use a triangle gives absolute stability, and this is the locking top nut, note the threads, and this is just small plate 4 centimeters and hip screw locked to the plate. by the locking nut. So we converted the dynamic hip screw into a locking hip screw. No more dynamization. GSK2 system works on 5 principles. Plate offers lateral stability. Sleeve prevents toggling of the screws. Lag screws inserted at 90 degrees to the fracture line compress the fragments. Triangle provides absolute stability, acts similar to protection plate, protecting the lag effect, no sliding. It's an angle stable implant. During the last 2 decades, there is a lot of research work is going on. After intensive research, three concepts have been evolved. One is the controlled collapse or impaction. Two, once intraoperative compression is done, achieved, no more collapse of the head, concept of absolute stability, and maintain the continuous compression. Third concept. Now the classification is uncontrolled collapse, DHS 3CS, controlled collapse of the Targon-FN synthesis system and Nephew's conquest. These are the absolute stability, GSK triangular system, locking plate, anterior inferior. And continuous compression occurs during the postoperative period by Smith and Nephew conquest and primary valgus osteotomy. These are the 3 new implants that have been introduced during the last 2 decades. The first was Targon-FN, Smith and Nephew conquest, and femoral system. We have, as I've told you, the fracture should be treated with the screws at right angles to the fracture line. Now we can predetermine the barrel plate angle to meet the fracture line at right angles. That is 180 degrees minus Powell's angle gives you the barrel plate angle. Note, for example, here, there is a 45 degrees Powell's angle. And if you see this quadrangle, 90 on each side, and this angle is equal to this angle, which is the which is the barrel plate angle here. This is 135 because 180 minus 45 is equal to 135. This is approximately, you should know what angle you are using. Now I will show you some cases. This is a 60-year-old man had a fall in the fields and sustained fracture neck femur, displaced one. This is the displacement that you see here. And then we treated with locking hip screw. And at 4 months, he united and started walking. Now, the steps to insert locking hip screw, that is LHS. First, fix the plate, barrel plate to the bone by a screw, and then insert conventional top nut to compress the fragments. Once the compression is achieved, you remove the conventional top nut and insert a locking nut to fix the DHS screw to the barrel plate. And then once the barrel plate is there, there is one more hole you can see here, and that is used to fix the plate to the bone. So this is the locking nut of the LHS, and this one is the conventional nut for the DHS. Now another case, 38-year-old male nurse sustained fracture neck femur in motorcycle accident. And notice there he has a global comminution, anterior, superior, posterior, and inferior. So we did again the same principle used, and triangle method was used. This was the triangle that used. We have now modified to DHS this. And at 4 months, the fracture united, and of course we give teriparatide to all these patients. Now this is another case of a 40. This is our first case done 2.5 years back. This is our first case, and this is how it went on. And 28 months later, walking full weight bearing. Our experience is 38 cases during the last 2 years, Follow-up is 4 months to 30 months. Average follow-up 11 months. Two are complaining of pain. One has frank non-union. The other one got infected and resulted in non-union, and then the infection was under control. Avian is now too early to predict because we need at least 2 years, all follow-up of 2 years. Results are really very encouraging. In conclusion, fracture neck femur heals by primary healing with intraoperative compression and absolute stability and no mobility during the intraoperative and postoperative period. GSKT system provides both compression and absolute stability. It works on principles of truss construct and engineering marvel, and it can be used for other metaphyseal fractures also. Thank you very much.
Thank you, sir. That was a fantastic insight into many things that we did not know about the intracapsular fracture neck femur, and the system looks really good. Is it available commercially?
It is available next month. You will get it.
Okay, sir. So there's one question for you from the audience, and that is, at what age can we cross the physis in pediatric neck femur fractures?
In pediatric fractures, yes, it can be done with the pediatric. We have also done the pediatric DHS converted into LHS. Yeah.
Yes, so the question is, at what age can we cross the physis in children?
Cost-wise?
No. At what age can we cross the epiphysis in children?
Oh, in children, it is, the epiphysis gives you 3% of the whole length of this. So it is not a big 3 millimeters per year that gives. So I think it is better to cross after 10 years. You can cross the epiphysis because then the 6 to 7 years are remaining. That maximum will cause is 1 or 2 centimeters. So I think after 10 to 12 years, you can cross the epiphysis.
Okay. Warid, you wanted to ask something? Yes, Atul.
Sir, very good informative lecture. I just want to ask, you said terifrac in every patient, even if the patient is young, teriparatide.
We have really very good experience with the teriparatide. All the cases do. Next month, you see the callus formation on the slight changes in the union side, and the patients are very happy.
You started immediately?
Even for other cases of non-union also, we are giving and with good results.
But you started immediately, sir?
Yeah, immediately on the day.
Okay. Thank you very much, sir. That was a superb lecture with a lot of new information on it. Thank you so much. So next we move on to the intertrochanteric fractures, and I invite Dr. Sunil Kulkarni, a senior orthopedic surgeon, AO trauma council member, a great AO teacher, and a great friend. Sunil, over to you for unstable intertrochanteric fractures.
Thank you, Chetan, and Team Sanchit, giving me this opportunity. And as Chetan has told me to make it, this is a video. So I'm making it very short for the purpose of what we do for augmentation of the intertrochanteric fracture. Can you hear me, Chetan?
Yes, we can hear you, Sunil.
Yes.
Augmentation, what is the rationale behind this augmentation is because of the most of the unstable fractures needs a stability. All fragments must be reduced, and lateral wall and the posterior medial wall reconstruction, and now added the anterior medial as well. So the most important, what we are now seeing the failures in our setup as well as outside is the lateral wall. So lateral wall is the main cause of failure in highly unstable trochanteric fractures. So why this augmentation is required is you require to get compression of all the fragments. So stability increases as better. It gives much better results as compared to, and we have now shifted to this stability. So the breakout chances, whatever implant you have used, the breaking is always there. Whether you do anything, any best of the implants in the world, best of the reductions you have done, still you get a failure. So, but that chances and number have reduced as compared to the previous one. So what we use is a lateral wall for the tension band, a simple procedure, the screws, and then now shifted to a plate for certain situations for all these unstable lateral fractures. If you see the x-rays, if you see this x-ray, it looks like the osteoporotic, but if you see the fragments, you have to measure it like a posterior medial, then the lateral wall, then the trochanteric tip avulge, and all these combinations will see the mostly comminuted fractures and see the lateral wall there. So now it is last decade, this lateral wall given a lot of importance, and that you have to decide that where to use the DHS or not, because it should be more than 20 millimeters should be the lateral wall should be available if you want to treat any such patient with the DHS. As the DHS is the commonly used, that's why I'm using. I have mostly we are now unstable fractures. We are treating all with the nails, so that we have to be very careful in choosing this. Every word we are saying that X-ray will give you the more important. But once the lateral wall, if you want to measure it, you can't just judge on X-rays alone. So you need to take a CT scan. So the CT scan will give you exactly how much is the wall available. If you see now here, if you see the different rotations, different part of rotate, if you rotate the CT X-ray, if you take the rotation, which we don't know, our X-ray technicians are taking the X-rays, but we don't know at what rotation they have taken. If you see how much is the external rotation, if you take every time the lateral wall, the length or whatever lateral wall available is changing. So it is necessary to have a proper CT so that you can reconstruct on the CT and see exactly how much is the lateral wall available, whether to choose a proper implant. And that is very important for to choosing of lateral wall and the implant procedure. If you see here, again, this is the lateral wall available and this is the wall available so that you can plan your blowout also, it can be prevented intraoperatively. So if you see this case, so many people are asking, why do you want to take a CT scan for all the intertrochanteric fractures, especially in a unstable fracture? If you see this fracture on X-rays, you don't see much. This can be done with the plate or a nail, whatever it is. But if you take a CT of this same plane, you can see how much is the comminution, how much the fragment, how much is the damage to the greater trochanter, how much is the posterior medial fragment is gone into rotation. So it is extremely difficult if you want to try this without the CT and then try to reduce this. So the CT is very important part of our reconstruction of the lateral wall with the augmentation. So how do I do it? Now study the CT, reduce on the fracture table, realign the fragments, rotations are corrected, and then we fix the nail and then do the lateral augmentation. So this is a bone model. So many for the PGs also we do this. These are the very fabulous instruments you require to have this encerclage wire passer. So this goes one anteriorly and one goes posteriorly on the. This is already nail is already passed. This is after the nail is passed. So initially we used to put it first and then pass this, but we find it very difficult because already been reduced. So we do not want to displace. Sometimes the wire comes in our way. So the first wire, the posterior comes out. This comes out from the wound, from the entry point where the bolts have been passed. The second wire goes here. Now you pass a finger or a same instrument for the posterior to the abductors because already entry point is already there. So you no need to make a separate entry point this. The same passage you can pass the entry of this, and then the posterior wire is passed again to this fragment and bring it to the outside from the entry point exit, so that whatever that it has taken the posterior part of the abductors, so that will go into the posterior part of abductors. So this is very carefully you have to do it. You can't just as close as possible to the bone. Then from anterior, we pass a clamp there and pull this and the posterior wall beyond the greater trochanter, so that this will go inside and we'll bring that wire to the from the entry point of the bolts where you have passed the wound is bolted. I'll show you the same video on the body. Actually, the patients have been done. Then you bring this wire back to the wound. This is for the percutaneous way of doing it. Though earlier we used to open it completely once we are not experienced it, and then we pass this and tighten this. This is a fabulous instrument from Synthes, which can give you an excellent maneuvering, and then you tighten this, and once this is tightened, the musculo-osseous fragments are compressed, all the fragments, the lateral wall, the posterior medial wall, and the anterior medial, everything is compressed with the simple technique of the anterior medial, also taken care of by this. So similar, again, I am showing the body. This is already nailing has been done. So the wires have been passed. So this is from the already taken the entries into where already bolts have been passed. Okay. So these two wires have come out. There is from the entry point, you pass this wire. That will go into the posterior part of your trochanter on the abductor point. So that is brought there. Take a small nick, then pass the wire and pull it from the anterior. And again pulled it back, so that it will come from the fragment compressing the anterior fragment also. And then it is compressed, the entire system gets compressed with the tension band. So it's a huge compression. You can just feel how much you get the compression. And see the intraoperative pictures, everything is compressed along with the fragment. So it is all the sutures. It's a percutaneous fixation. It is absolutely very simple. Initially, you can do with the plane with the and then you can try this. This works very, very simple. So this is, if you see this case again, very 96 years old man. Then this is a CT scan. If you see this CT scan, the all spectrum of fractures, if you see these kind of unstable fractures will not be fixed alone with this. And then we fix with patient can walk after a few days, and this is completely united. We have done this for the reverse obliques. Now we have started with the small plate again, to fix the small plate on the lateral wall, and then the small plate. This is a simple plate which goes into a trochanter part, and then push a plate there. After the passing the implant, the nail is already passed, and this plate is fixed, 1 or 2 screws anteriorly and 1 in the distal to the. This is very important. So many people are telling me that reverse obliques, if you nail acts as a lateral wall, but nobody is showing the failures of reverse oblique with the nail. I have seen in our own series also that whenever you get such fracture, even if you put a nail properly with the Cyrus nail 4 bolts, even then there is a displacement of the fracture once the patient starts walking. So what we have started doing this is a simple nail with the plate this way. Just put a small plate after the fixation of the nail, and this will suffice. This will give you excellent. Like I said, the pendulum is swing towards the success once you start using the longer the nail in reverse oblique fractures. Whenever we feel there is a lateral wall fracture, even in intraoperative, it occurs sometimes in osteoporotic bones. Then and then you can just change the nail, change it to long nail, and put a plate. So that will take another 10 minutes more, but your results are so good that they will go ahead with the healing. See the comminuted lateral, again the reverse oblique, the similar flat plate. You can manage a very malleable plate. It can take its own course, valgus reduction, and then you can fix it. Now the greater trochanter split is also very important. Many times we see it, once we start doing CTs, you can see this fracture is very high, almost like a neck femur, but it is a very high unstable trochanteric fracture. If you see the split of the trochanter, this is at least undisplaced split. We see so many displaced split with almost about 1 or 2 centimeter displacement of the greater trochanter. What we have started doing now is to fix this as a percutaneous way of doing it. This is a screw which we fix it as a lag screw, convert that split into a one, and then put a tension band wire over it, and then forget about it. So similar patient, if you see here, that is what is done. We have done this anterior posterior screws reconstruction of the what is called augmentation, and gives a superb results when we reconstruct this greater trochanter, which is a very important part of abductor mechanism. We have published this article in Injury in way back in 2017. We have studied 84 cases without augmentation and 84 cases with augmentation, and we have this augmentation method gives superb results after especially in unstable fractures and the split greater trochanter fractures. So there are complications. I don't see any there is no technique without complications. So breakage of wires, screws, implants, everything we see. I'll just share one minute. This is a case done where it looks like a very simple trochanter for us for the nail, and we put up because lateral wall there is a CT scan. If you see, there is a all spectrum. So we decided to give a good augmentation and a plate and nail reduction valgus. He came with this. See, this so much time of breaking of the wires. The wires are broken, everything is broken, but still the fracture has united. But see the fracture of breakage of the wires. So he wanted to remove these wires, but we removed the implant and wire, only one wire for his souvenir. So everything is, but it is healed. So why it has break? The wire, in spite of reconstruction, why this has broken after so many years? So we don't know, but still there is a possibility of the forces acting on this, and these forces have been prevented by these wires or tension band fixation, and it has allowed the fracture to heal, but they have broken. So wires have sacrificed their life to heal the fracture. That is the important message I wanted to give this. So there are so many references. I don't want to go into the details. So in conclusion, each IT fracture is different. We can't just classify the IT fractures. Once the CT scan has come, there is no classification can give you a CT scan or a classification to the. So I make it stable and unstable. That is the only big classification. So all destabilizing fragments must be stabilized. Each and every step must be carefully planned. 3D CT is must for all planning. It just takes 100,000, 2,000 rupees for the extra for the patient, but your results are so good that the further complications of non-union and breaking out, because eventually the elderly patient comes with the trochanter fracture, and he will end up, if complication occurs, he will end up into a replacement, which is very not good for our society, especially those who are sitting cross-legged and squatting for the toilets. And the special instruments are required now. The Indians have also come out, so there is no need to have a synthes. But if you have a synthes implant, it will be really good because the precision they work is excellent. So virtually we can fix any unstable fracture in any age. That is very important. So age is not the thing which you plan for joint replacement only. Only thing, the comorbidities and other things are there compelled to so that you can plan it. But virtually we can fix any fracture on the intertrochanter fracture. So take home message is abductor mechanism plays a very important and major role. Augmentation is must for all unstable intertrochanter fracture. I don't say that all are required, but in my hand, I always put some extra, which takes another 10-15 minutes. But the results are so good that encirclage wire stabilizes the lateral wall, the posterior wall, displays the lesser trochanter along with the sauce, and especially the medial column, which we can bring it on the medial side. So the varus collapse is almost negligibly prevented. And now the lateral wall, especially for the reverse obliques, I use a small plate. You can use any plate, not necessarily that plate, but any plate, recon plate also will suffice. One screw in the trochanter and one screw in the shaft, which can negotiate your nail already there. Thank you very much for your kind attention.
Thank you, Sunil. That was an excellent talk and the technique. Just a few quick questions for you. So you would advise CT scan in all unstable fractures
Yes.
and augmenting the lateral wall always, even if you're doing it absolutely percutaneously, you would augment it in each and every case?
Any lateral wall fracture is there.
Yeah, obviously in lateral wall fracture.
Any lateral wall, all we are stabilizing it by any means, because whatever we have seen failures, without those who have done, we have analyzed that those fractures have also gone. I would have shared one more recently done in this corona pandemic in June 2006 to June 2020. So he came yesterday with the broken implant. So in spite of nail and plate, it has failed. It is
so you feel the concept that the nail acts like a lateral wall is not really...
That concept I absolutely don't agree. I have asked all the people internationally, Paulo Barbosa and they say the nail acts as a lateral wall. I just showed them, asked them, show one reverse oblique fracture which has failed with the nail inside. If nobody has shown yet, just show me one X-ray of lateral wall with the reverse oblique which is failed. So if the nail is acting as a lateral wall, why this fracture has failed? And you also seen, Chetan, that so many reverse obliques we have done with the old PFN, it has failed. In PFNA blade, it has failed. So we don't know what is the reason, in spite of reduction, and the bolts are going through that lateral wall fragment of the reverse oblique. Still that fails. I have that cases, so that's why we shifted from nail and plate combination.
No, even I prefer augmenting the lateral and the posterior medial wall with tension band when required. But between the tension band wire and the plate, what is your preferred technique?
For exclusively reverse oblique fractures, I use the plate. The rest of the things which I use, all tension band, no plate. Sometimes the nail and the plate, the reverse oblique combination, like many comminution, then we can use. But 90% of the reverse obliques now, only nail and the plate. Long nail, not short nail, long nail.
Because the problem is finding the right plate for the proximal femur, you know, even you don't have good plates which...
A simple recon plate. Just 1 2 screws. Don't use a locking plate, because with locking plate, we don't know what is the direction which we want to put a screw.
Yeah.
Because locking plate will give you angle stables. We have no choice to change the direction. But simple plate, which will give you a maneuvering of the 6.5 screw in the trochantery and one screw, any part of the in the distal fragment, which already nail is there. So you have to negotiate that nail and put that screw.
Okay. Any other questions, Atul?
So there are questions in question box. Why do you need 3 locking screws when you have one plate and one cerclage proximally, distally?
You mean to say distal fragment?
Yeah, it's about the distal locking screw.
Yeah, in the distal nail.
Yeah, actually it is not necessary for when you use a long nail, but I don't want to take chance, because the rotational instability is the main cause of non-union. All these metaphyseal areas which causes the rotational instability. So the anterior-posterior screw will give you a rotational stable. However, some people are not doing even distal locking as well, like Professor Haldar. He doesn't put any distal lock, still he shows good result. But it's fine. So I just don't want to take chance. But once you have put the plate, then a distally anterior-posterior screw is not required. Just additional, I just take a precaution. We don't want to post again for the non-Indian. That is the only worry.
Delegates want to see that wiring technique you demonstrated on bone model. Is it there on YouTube, the video?
Not yet, but I can put it on YouTube.
Yes, if you can put it on YouTube, then all the delegates can see it on the bone model video which you just demonstrated.
Sure, I'll put it.
Sunil, there is one more question. In minimally invasive cerclage, how do you avoid anterior structures and posterior sciatic nerve?
That we have to be that's what I'm telling you. You have to be very careful. While just because
in a obese patient.
Obese patient, yes. Or then you have to take a little open more. You should be able to pass properly while filling the bone. You have to be as close as bone to the posture. And you have to be very careful in, because you have staying laterally on the anterior part. We have to, the neurovascular is far away when you take out laterally. For those who are not sure about, they can just little bit open it and then pull it from inside. But
Yeah.
it's of injury while want to do it. So it is better to pull it anteriorly, one wire with a slim clamp, and then pull it back from the, already you have taken incision to put the bolts. Same here, we have to use that.
So I think just to add to that, Sunil, initially you may do it with a slightly more open incision using a simple wire passer. Then you get the hang of doing it with a percutaneous technique.
The wire passer has a different angle.
I know.
You do this way, the patellar like a wire passer per tendon, which is not at all easy to do it. I'm telling you.
No, these instruments definitely help you when doing it, but the tip is to do it slightly more open when you start doing it.
Basically, the wire passer is very sharp, and if you want, sometimes you hit it, you may injure the nerve or artery. Basically, that is a very important. You have to have a proper instrument. You can't just compromise with the instruments. If you have to have a good surgery, you have to have a good instruments. You just can't. And no orthopedic surgeon is poor. They can afford it. There's no.
So there are two other questions. What entry should be taken if it is a thin GT fragment or the fracture passes through the GT?
It is always on the medial side, which I don't mind going through the piriformis fossa as well if it is smaller.
Right.
On the medial side, and eventually the nail will pass through the fracture side only. See that it doesn't go into the lateral side. Lateral side, it will go into varus. That is very important.
Another question is, do you prefer supine or the lateral position?
Supine position on the fracture table.
Okay, I prefer the lateral position. Either ways, whatever you are used to, you can be comfortable with.
Yeah, absolutely.
Sunil, there are 4 or 5 questions for you in question box. So can you directly answer in the chat box?
Okay.
You can maybe type those answers in the chat box.
Chat box and question answer. Okay. Okay. Which wire anterior posterior is going towards? What are your tips for close nailing? What are your tips to do close nailing in such cases? Such cases means I didn't get it. Any trochanter fracture?
Unstable trochanter, I guess.
Okay. So that is the reason is very important is to reduce the fracture. That is very important. You can't just pass a nail without a reduction. You have to reduce the fracture, especially the anterior medial. There is a maneuver available now. We can use a joystick and reduce it. And then you can pass, and rest of the things, once you nail is passed, the rest of the fragments, if you want to compress, use those tension band wire to compress the osteomuscular structures, especially on the, you can pull the posterior medial, even the lesser trochanter also you can pull it, which is very, very uncommon by the DHS. You can't just pull it, but once you can pass it. But be careful, don't go below 2 centimeters below that lesser trochanter, because there is a available which supplies to the medial side. When to put only static
and when dynamic.
So I use all the static screws because I believe if you put a dynamic, there is a movement can occur once patients start walking, and there is once to start moving, there is a toggling occurs, and that toggling will cause a head effect. That's my concept, maybe wrong. So I don't want to take chance. It is a static locking. Everything is locked through a jig. It takes another 5 minutes to make one more screw and put it. What's the big deal to put one more screw? It doesn't matter. It doesn't change your rate also, because the company is going to charge you for 2 screws and 2 screws down. So it doesn't make any sense to keep it only one. I always put the synthesis, that blade I have abandoned. I have stopped using blades. I came back from blade to again to the 2 screw good old PFN, because I have seen so many complications of blade again. So I shifted back to a nail. What if lateral wall fragment fracture is site comes at, what is the further?
At the locking bolt side.
Lateral wall fragment site comes in your screw site.
There are many questions coming up. Sir can type also in the chat box.
Okay,
Other talk is going on.
okay, that will be great.
Right.
All right.
So we move on to the next talk, the most interesting part of the proximal femur, and that is the current evidence on proximal femur fractures by none other than Mohit Bhandari, who does not need any introduction. We have been reading hundreds of his papers on practically everything in orthopedics. So to educate us about recent evidence, Mohit, once again to you.
Oh, thank you so much. Hopefully everyone can hear me okay.
Yes.
Great. So clearly we have about 15 minutes and I'll do my best to stay on time here, but I'll focus primarily on the femoral neck, but I will touch upon broad issues that relate to proximal femur fractures. You've had two excellent talks, and I'll tell you, when I was listening intently, if I take one thing away from Dr. Kulkarni's talk, look at this slide. It's a critically important slide. And I think his message to me that reigned was what he said this morning. The lateral wall is the main cause of failure in highly unstable IT fractures. I think we have to really appreciate that and think about our techniques as we go forward. I also look at the first presentation. Now, this is me and Dr. Kulkarni, and if anyone has ever had the privilege or pleasure of interacting with Dr. Kulkarni, it will be all but 1 minute before he opens up his pen and his pad, and he does what he has done for countless decades. He begins to educate you on principles. And today, if you remember anything from his talk, I think it's really important that all of the members take away what he said. I think this was his fourth statement he made, which is mobility is contrary to the principles of absolute stability. And he raises an important question. Why would we allow this for femoral fracture healing? There are two critical slides that I took away from his talk this morning, and I wanted to make sure that I at least acknowledged how important it is to understand the anatomy as well as use the anatomy and biomechanics as we think critically about innovative techniques. Because the reality is, even if we do publications, and I'll be talking to you about 4 key publications that we have done. We've done a review published in the New England Journal of Medicine. We have done a trial of femoral neck fracture arthroplasty, a trial of femoral neck fracture fixation, and a trial of how quickly should we treat femoral neck fractures. Interestingly enough, in 1994, I had just started my orthopedic training, and I started this at McMaster University. I remember being told at that time, you must read this paper. This is an important paper in the Journal of Bone and Joint Surgery by a Professor Mark Swiatkowski. And I read that paper at that time, and I actually, as many of our trainees might have, as you think about reading a paper from Dr. Kulkarni or Dr. Sunil Kulkarni, any of the of the great presenters before me, you say maybe one day I'll have the ability to write a paper just like this, and maybe I'll have an opportunity to write with that exact individual. And it took me 23 years. And here we are writing what we felt was the update paper in the New England Journal of Medicine with Mark Swiatkowski. So I say to all of you who are trainees, never give up your dream and your hope of establishing a strong academic career and moving things forward. But let's begin with this problem. Why are we even talking about femoral neck fractures? Why is it such an important thing even in 2021? Well, look at this. Almost 20 years ago, we knew this. The disability associated with hip fractures is among all types of disability ranking in the top 10. We also know that mortality rate remains high. Morbidity remains high. There is a profound impairment of independence. And as you've just heard, many of these fractures historically have required revision surgery, probably because we haven't been thinking carefully about what types of implants and techniques actually can reduce it. Take a look at this paper. This is a paper we wrote some years ago, and we were looking specifically at death after hip fracture. In the 1980s, 1990s, and in the 2000s, look, mortality rate actually increased despite hundreds, if not thousands, of studies focusing on hip fractures. We weren't necessarily improving major outcomes. Why? What were we missing? And the truth is, maybe the optimal approaches to fixing or replacing have remained inconclusive. We maybe haven't got the right approaches and sorted. Right? In what other field would we tolerate this except for 50 years in the management of hip fractures? And in fact, in the end, it may be less about even how we treat the fractures, but how quickly we treat the fractures and how dedicated we are to the post-operative medical management when we talk about mortality. So let's fast forward now to where we are. Well, is it possible that quicker surgery in hip fractures can save lives, or does it? Well, this is a study that was published in The Lancet in 2020, and we called it Hip Attack. Why did we call it Hip Attack? Well, we called it Hip Attack because we believed that getting a patient with hip fracture treated quickly can alleviate all of these problems, because we know with hip fracture, while waiting for surgery, they're immobilized, they have pain, they have bleeding, there is inflammation, stress, hypercoagulability, and all of these things lead to all of the critical issues that we see, and we've seen an increasing mortality rate. So maybe there's a way to resolve this. And also think about this historically, my friends. Look back at myocardial infarction treatments. Look at ischemic stroke situations. They were all acute conditions, all had very poor outcomes, and outcome was dramatically improved by rapid treatment. Well, hip fracture is a very acute condition, has a very poor outcome. So why wouldn't its treatment also be improved by rapidness? So this trial, as you can see, had many patients across many centers in many countries. And obviously, we're focusing on around the world, but you can see India played a very important role in helping us recruit the study. But here's what we learned. We learned that when you take patients to the operating room, we're talking very quickly from the time they come in with a hip fracture, any hip fracture, they have a lower risk of delirium and urinary tract infections. They mobilize actually quite faster. They have a shorter length of hospital stay. And here's what we found, which was fascinating. There was a significantly fewer deaths in those patients that actually came in early with myocardial ischemia. So the concept of saying that we should wait and treat those patients first is probably more of a death sentence. We should get those patients to the operating room, because when we did, we saw all those elevated troponin levels come back down. So think of this. Faster time to surgery may in fact save lives and reduce morbidity. And maybe we should be rethinking this concept of stabilizing patients for all their medical comorbidities and having them wait, because the belief here is that the key way to manage their inflammation and their hypercoagulability, which leads to all of these horrible events, which are the cardiac events, are to fix that fracture, reduce the stimulus for that inflammation. Okay, so now we've got our patient to the operating room as quickly as we reasonably can. We are ready. What do? You've seen, two excellent talks before, and we talk about what is the approach? What are the things we think about? I'm not here to tell you again and repeat what two excellent presenters have said before me. But I do think we should be thinking about where we have the problems, right? When we talk about femoral neck fractures, way back when we did a meta-analysis of randomized trials, and what we found was that there's a real shift in the pendulum towards arthroplasty. Why? Because arthroplasty, when you remove the head, led to a decreased risk of revision surgery by 77% compared to internal fixation. Okay, well, what were the problems? Well, non-unions were very important, and AVN was very important. And you can argue also, if you look at this particular technique that you're seeing behind me on the screen here, that technique may in fact be the wrong technique for the reasons that we've already talked about. These fractures slide and fail, and they fail in varus and they collapse. And this historically has been considered a good outcome, but it's a bad outcome. In fact, but even if we go, let's say, to arthroplasty or hemiarthroplasty, there's still a risk, because you have to remember that doing arthroplasty while improving function, total hip arthroplasty still has high risk of dislocation. So there has to be some discussion around these two opportunities. So let's talk about the first one. If we are going to replace it, just generally replace it, what would be the optimal choice? And this comes back to the trial that we had published in October of 2019. And we had this launch way back in September, where we unveiled the results to a large audience at the Orthopaedic Trauma Association at the same time as the paper was being published at that moment at 3:15 in the New England Journal of Medicine. Many surgeons, many countries were involved in this trial. And simple question, what's better with respect to unplanned secondary procedures within 24 months? Now, keep in mind, we didn't look at 5 years. So this is just looking at that first 2 years. And if you look at the types of patients we have, these are low energy fractures, and you can see about 700 patients per arm. Mostly female, mostly in the 70s, independent ambulators coming in with a subcapital fracture. So that's basically what we were talking about in this particular population. And at the end of the day, it did not make a difference. So the point I'm trying to say is there was no difference between a total and a arthroplasty and a hemiarthroplasty. In this case, a modular unipolar or a bipolar, so a modern day approach. There was no difference in mortality. There was no difference in function. And actually, if anything else, there was a trend towards more serious adverse events with total hip compared to hemiarthroplasty in that first 2-year period. We can discuss the nuances, and some of you may argue, well, as you look longer out, maybe the total hip arthroplasty becomes the better treatment. In fact, we can have that discussion about what the options may be. But here's what I would say. Among patients with displaced femoral neck fractures, the incidence of secondary procedures over 24 months did not differ between a total hip and hemiarthroplasty. Total hip arthroplasty resulted in a clinically unimportant improvement in function and quality of life within that 2-year period. And total hip arthroplasty had a potentially increased risk of serious adverse events. Early on, it was all driven by dislocations that were happening in the total hip. Later on, in the second year, we started seeing the bipolars and the hemiarthroplasty starting to have revisions because of, complaints and pain. So you can start seeing the shift in the types of complaints they were having. Okay, well, it doesn't mean that arthroplasty is absolutely perfect, but we really have moved this pendulum, right? We've moved this pendulum towards abandoning fixation. But if you go back to make the argument for why we would fix fractures, well, there's less blood loss. You can argue OR time was a bit more efficient. There may, in fact, be a possible decrease in mortality risk because it's a lesser invasive procedure. Yes, and although revision rates have historically been high, 65% of patients don't ever need a reoperation. And when asked, patients actually prefer it. We did a study many years ago when we asked patients to, compare and contrast the options for a fracture. Would you like to keep your hip and have it fixed with the potential complications, or would you like your hip to be replaced with the potential complications? And over half said, I'd like you to preserve my hip because I want to have a less mortality risk. I want less invasiveness. I want potentially a shorter operating time. And I'm concerned about blood loss. So there's lots of issues. Let's go back to that paper in 1994 by Mark Swienkowski. He talked about the perfect reduction. He talked about parallel cannulated screws. He talked about that critical inferior and posterior screw. And he also talked about where that inferior screw must be. And he was also a proponent of the anterior capsulotomy, believing the pressure buildup in the intracapsular could lead to potentially some AVN. We just heard from Professor Kulkarni talking about, some of the important papers by Zhao that talk about, what the issues are. So I think we have to go back and really understand the anatomy as we think about what we're going to do. And maybe what was considered standard of care is no longer appropriate in 2021. This was considered a successful X-ray. And once again, you heard, and let me remind you again, that sliding in many ways, while it was aimed to help with initial compression, is not the way you would normally want to heal this fracture. Why? Because look at the abductor moment arm now. Look at the lurch this patient is going to have. Look at the functional disability. So, we look at patients as a whole now and say, just the X-ray is not the success. It's how the patient actually moves and functions that makes this a success. So while we might have a healed fracture, we have shortened it dramatically. And that in and of itself is a huge problem. In fact, we did some of this work, and you also heard about Parker's work that have done this. But very early on, we did a prospective study that looked at all fractures of the femoral neck treated operatively tend to shorten. In fact, 30% shorten. And even in the undisplaced fractures, they continue to shorten. A third of those shorten. So that led us to our next trial, the large faith trial, which was looking at what should we do? Should we try a different approach? Should we try a more fixed angle device rather than multiple cancellous screws? Multiple centers, and you can see once again, our in India had amazing support for this trial, and we were grateful to them. What we learned was there were fewer reoperations with a sliding hip screw device. Was it perfect? Absolutely not, but it appeared to be better than the single approach of the multiple cancellous or cannulated screws. In fact, the sliding hip screw seemed to be better in the displaced fracture. It seemed to be better in the base of neck fracture, and also seemed to have some advantageous impact on smokers, which we weren't entirely sure. But the two other ones were really important for us to think about. Now, if I go back for 1 second, I would put forth to you that the sliding hip screw gave us a bit more insight that a fixed angle side plate may be important. But you see the evolution. The evolution is maybe what we want is we want initial compression, but we want, if anything, no shortening or controlled sliding, if any is sliding at all. Because remember, movement is the problem in the femoral neck, right? We know that. And so we want to be very careful about how we design implants. And you've already had a wonderful presentation early on by Dr. Kulkarni, who talked about that. So I won't go into that, but we must be using evidence to help us move forward. Now, what happens now? We've done our procedure, we've got the patient to the operating room, and now it's about the post-op care. What do we do in the post-operative period? Well, there's been studies that said if we have dedicated geriatric groups, if they're interdisciplinary groups, we can actually reduce the risk of death. Well, okay, well, what does that mean? What's a geriatric unit mean? Well, it's a group of people in a team that's expert in saying, we're going to help this patient mobilize early. We're going to manage their pain appropriately very quickly. We're going to protect them against pressure ulcers. We're going to make sure that we have an appropriate plan around all of the other disorders that happen very, very early. We have to be vigilant about identifying confusion and managing delirium very quickly, and we have to manage their nutrition. These are things that are often forgotten on the orthopedic ward. So when we do this, we notice that we actually have better outcomes in our patients. So what's the road ahead? Well, we have an unacceptably high failure rate, and that demands action. No matter where we are, we have to find ways to improve this because hip fractures are going to continue to increase worldwide. In fact, if you look at the evidence suggests that the shift is going to be the majority of new hip fractures are likely going to be coming from Asia, not in North America and in Sweden and areas in Europe. We're going to see the shift. So if there's ever been a time to be thinking about how to figure out whether it's an arthroplasty or whether it's an internal fixation, it's now. And maybe it is about time. Maybe rapid treatment may be the answer. We have to think about, who rapid treatment will help, but generally also understand that delaying fracture care in the hip leads to a number of other medical complications that often leads to very, very bad outcomes. So we should be thinking about how we can expedite that care in our system. You heard also that biologics is already playing some role. You heard that some patients are getting, a teriparatide routinely when they're getting fixed. Absolutely, we should be thinking about biologics in the broader system. Local biologics have been tried and have been difficult. The hip fracture area is a very difficult area to be putting local biology into. And maybe it's a more systemic biology that we're dealing with because the problem for many hip fractures is a systemic issue of, bone of bone quality. So osteoporosis, as you know, is a big problem here, and thinking about how we can manage that. And friends, we see fractures all the time. We have questions all the time. We have new innovations. We should be thinking about how do we test these innovations and let the world know when something works. So I take this moment just to thank you. I tried to keep it short, but I want to remind you all that we will provide you all with lots of free access to ortho evidence from which most of this information has been taken. Thanks all.
Thank you, Mohit. That was absolutely amazing. There's a question for you. It's about the biologics. So do you have any evidence on teriparatide in proximal femoral fractures?
Right. So Eli Lilly, maybe 5 years ago, engaged with our group to help them start a trial that was going to be looking at teriparatide. And the challenge we had was there was a hard time recruiting patients for this trial. And we ended up with a smaller group of patients, and it didn't work out we didn't get to an answer because we weren't able to recruit enough patients for that trial because there were so many other issues assorted. So I think there's been a lot of anecdotal information around the use of teriparatide being useful. Clearly, for the use of osteoporosis, it's important. I think we've seen so many, Chetan, we've seen so many biologics fail around the hip that, it's still, I think, it's still part of the planning process. I'm not sure if anyone else here uses biologics routinely, but generally this is more this is a technique, a time, and an approach more than it is biologics right now. The future is, who knows what'll happen.
GSK, sir, any evidence you have on use of teriparatide, proximal femur? Kulkarni, sir?
No evidence. There are only anecdotal papers published, but our experience is very good. We have used on a large number of patients.
Okay. Irrespective of the age.
We have to publish it. I agree with Mohit that we need evidence-based teriparatide, but we are using anecdotal.
No, but irrespective of the age you use it, or you use it only in geriatric population?
No, we are using in even younger patients, and we give it only for 3 months, even in younger patients.
Yes, Sunil, unmute yourself. Unmute it.
Mohit, can I ask Mohit one question to you?
Yes.
What is the evidence of lateral wall reconstruction, what I was discussing about in your literature search, and whether the McMaster University in Canada, they do it? What is your view of the nail acting as a lateral wall?
Well, I see Dr. Petrosor on video here. So I'll ask him to speak to maybe the technique issues that he may be using. But let me share to you the challenge we have, Sunil, always, Dr. Carney, is the same thing, which is, we have expert surgeons like yourself, using a technique. And all I would say to all of you is document your technique, and let the world know about your results. Because what happens is, when we say that, we don't see the results that others are presenting, then it's up to us to demonstrate, well, look, these are our results with the same problem. And you see, we're not getting your results. So therefore we have a different technique. But to your specific question about trials, we try to look at comparisons, Sunil, lateral wall fixation, augmentation versus not. And there are not a lot of trials that look at that. So many of this is unfortunately surgeon-based. So when you have to go against another group that has something contrary, the only thing you have, friends, is your own data. So collate it and present it.
Yeah.
I may ask Dr. Petrosor, just in general, his preference for, nailing or using augmentation, and particularly with interest in the lateral wall.
Yeah, and I completely agree. A lot of those intramedullary trials versus extramedullary trials wash out the effects of any little fixations of the lateral wall. So while we all kind of gravitate to the IM nail for the unstable intertrocks and foreparts because of the biomechanics, you're right. Whether we stabilize lateral wall or not, I personally do not do it routinely all of the time. I do believe that the biomechanics of the nail provide some degree of support. However, if I'm in there and I notice some significant serious continued instability, or it's still off and you've basically got a screw into the head and a nail and everything else is completely gone, then I may look towards some sort of fixation strategy for the troche. I'm not routinely using cerclage, nor am I routinely putting a plate on though.
Brad, and I might just jump in and say, when we talk about nail versus sliding hip screw, that large comparator between, treating with the trochanteric fracture, they always say, well, there's, the huge advantage to a nail comes in the unstable fracture patterns. The unstable fracture patterns that Sunil says, we miss the lateral wall. So every time the nail has been shown to be superior, when you look at some of the treatment of the unstable fractures with the sliding hip screw, they're not really often using the augmentation approaches. If you augment the way we were just taught to augment, I suspect we would start seeing that the advantages of the nail becomes less and less.
Yeah, and I think, didn't George Hadakavich look at that a little bit in terms of using the trochanteric extension plates with these constructs, which basically speaks to the lateral wall concept. And then you're right, you see the effects of the nail kind of come down. especially with the trochanteric stabilizing plates.
Correct. I know, Dr. Kulkarni, you were trying to get into a question here. Yeah, GS Kulkarni was trying to say something. Yeah.
Can I ask you one question? Now let me know any evidence how the fracture neck femur heals. That is the very crux of the whole point. If it heals by primary healing, then you need an absolute stability. If it heals by a cancellous bone, then there is no question. So then you can allow some amount of sliding. So
And I'm when you say this, when Professor Kulkarni asks me, it feels like the teacher asking the student for the answer. And I fear that you have spent many more years thinking about it. And if you can't give us an answer, I fear we don't have one. So I won't even dare try to give you an answer, sir.
That was a good answer, Mohit.
I saved myself. You see how I do this?
Yeah.
Even at 50, even at 51, I'm a student to Dr. Kulkarni. Just remember that. Yeah.
Can I ask you a question?
Sure.
So what's the next trial look like, out of curiosity, for hip fractures?
Well, see, the challenge we have is the following. So you just seen, if you look at the evolution of where we are, right? We think we have some involved, we think there might be a place for arthroplasty. We think there might be a place for more a modern day implant. So I think for fixation, if we want to revisit fixation, we should be going back and looking at modern day fixation and advancing on what we already know about the fixed angle devices in the hip, but doing it very large and comparing it to the standard, which might be an arthroplasty. So a modern day femoral neck fixation to arthroplasty would be an interesting trial. We tried it many years ago, and it was an absolute problem because the fixation back then was the wrong fixation. So it wasn't. We weren't playing fair in that. So I think that would be the way to go, Brad.
Right. Okay, thank you very much, Mohit. That was a really good session on proximal femur. I thank Kulkarni sir and Sunil one more time for the excellent talks. And now we move on to the knee. And Warid, is the video ready?
Yes.
So we move on to the distal femur, and we have an excellent video on the nailing of the distal femur by our IOA president, Dr. Shiv Shankar, who is not here in person, but he has posted a video and where he wanted us to play it in this course. So I request Warid to start his video. Dr. Shiv Shankar is again does not require any introduction. He has been a pioneer in nailing techniques. He has many innovations to his credit, the Solapur innovations as he calls them. And he's the current president of Indian Orthopaedic Association. In spite of being busy with the AACon, mini AACon in Jaipur, he has given us this video. We really thank him for his contribution to this course.
Hello everybody. I'll be talking about advantage of distal femoral nailing. I'm thankful to Dr. Parag Sancheti, Dr. Atul Patil and Dr. Chetan Pradhan for having involved me in the Pune trauma course since inception. We have been treating these fractures by varieties of plate before the nailing became popular. Once the locking plate became popular, the anatomical locking plates were the mainstay of treatment for these fractures, especially the supracondylar fractures with intra-articular extension. The locking plate does give good results, especially if the fracture is not comminuted or if you use double plate. Now I'm talking about why nailing is better than plate. But unfortunately, if there is comminution medially or there is bone loss, locking plate is not the answer, and we all have seen the end result of improperly done locking plate as well as due to the severe injury pattern. This locking plate works if the proper fixation is done and especially the medial comminution is addressed with the additional plate. So this is a very major surgery one has to do, not just the lateral locking plate. So this can be avoided with nailing. That is the reason why I am doing this presentation. This article by Anderson in 2009, which talks about when you fix a distal femoral fracture with a locking plate, there is hardly any callus in, it's zero callus at the end of 4 months. Whereas when it is treated with a interlocking nail or a intramedullary nail, you can see that there is 330 millimeter cube of bone present. So that is the reason why I prefer to use locking nail rather than a plate. This nail can give axial micromotion like Ellis row and throw a lot of callus both on lateral aspect and medial aspect. That is one of the reasons why locking plate is losing its importance, and they are coming out with the bar locking cortex, which will have subtle instability near at the plate by making a hole little larger and the screw not having a purchase. This movement which happens within the plate will lead to axial micromotion, and the bone will throw a lot of callus, as you can see in this example with a bar cortex locking plate is being used. When we do the nailing just with lateromedial locking, there is a bell effect sometime, and that will lead to malunion or non-union. To prevent that, one can use polar screws on either side, or one can also use multi-locking bolts in all the directions. As I said earlier, nailing gives better callus formation and multi-locking gives better fixation. Recently, we have got multi-directional locking distal femoral nail, which can get interlocked within the nail. There are threads over the bolt and there are threads inside the nail. So this locking bolts need not have to be put. How I do? I normally do at the end of a simple table, and I should be able to flex the knee. I keep the thigh on a triangular pillow so that the fracture gets automatically reduced in that position. So one should be able to flex the knee to 90 degree at least at the end of the table is the basic requirement. Few simple cases: fracture neck with fracture distal femur, treated both with keyhole surgeries, as you can see. These are the pictures after fixation. This is a very old picture of 2008. Few more simple fractures again treated with a supracondylar nail. A polio patient, a medical student with polio supracondylar fracture treated with a nail, and patient having good function at the end of the treatment. Little complicated case, intraarticular fracture with supracondylar comminution treated with the intraarticular fixation with screws, then nailing with end result good. Another similar case, again you can see that the intraarticular fracture was fixed with percutaneous screws, which doesn't come in the way of the nail if you put it anterior or posterior to the nail. And this is the function at 6 weeks in the same patient, and the patient had an excellent result at the end of 4 years before the implants were removed. For comminuted C2, C3 type of fractures, I do open the fracture and plate jigsaw puzzle with all the fragments, and you can see that this is a very bad comminuted fracture treated with a nailing and aligning all the fragments around the nail with screws, giving good results. Another fracture, again, similar way treated. Even this patient had a fracture patella. Again, that also was treated with percutaneous screw fixation. No, it was an open surgery done. To the same incision, we fixed the patella also. Patient had an excellent result. And then you can see you can bend the knee to 120 degree without any problem. This is after the implants have been removed. Another C3 type of fractures, again treated with a similar way with a nail and interfragment screws for the articular fragments. Patient had a good result at the end of 4 months. This is by about 9 months, he had about 110 degrees of knee flexion. Finally, he ended up having 120 degrees of knee flexion by the time we had removed the implants. This case, I will be demonstrating the video. A supracondylar fracture in an elderly 75-year-old male treated with the multi-lock supracondylar nail. This is the surgery you asked. This is the position for lateral view of the C-arm. The patient is positioned at the end of the table over a triangular pillow. This is the end of the simple table. You can see about a foot length. And the knee, both in AP and lateral position. This is the inferior polar patella. At the inferior polar patella, I am taking a midline incision. I am hitting the bone and cutting vertically or splitting the patellar tendon in line with the incision. Now I am inserting the solapur sleeve or the protector sleeve, which is beveled on one side. The bevel end will look upwards so that it will put on the lateral condyle from the notch. Please. Shoot. अजून थोडे खाली. Shoot. Yes. Guide pin passed through the protector sleeve or the solapur sleeve. The entry site is not exactly in the center of the notch picture. It is at the anteriormost part of the Blumenstadt line, as you can see here. The guide pin is then advanced parallel to the lateral cortex in AP and parallel to the anterior cortex in lateral picture, as you can see in these CM pictures. Now, this is a 10 millimeter end cutter, which we normally call as cheese cutter, which will pass over the guide pin and make a hole in the distal femur, which is 10 millimeters all around. Once the guide pin position is confirmed, the entry site is done with a cheese cutter or end cutting reamer, which is 10 millimeter in diameter, which is seen here passed over the guide. Now, I'll remove the guide pin and insert the plain guide wire to the same cheese cutter or the end cutter. Shoot. Save. The fracture is easily reduced in that position. Without any problem, I am able to pass the guide wire into the proximal fragment, and I'll just hammer this to get fixed in the protendic region. This work of this is over. Now we'll ream the canal sequence from the cannulated end cutter. The guide pin is removed and a flexible guide wire is inserted. The guide wire is advanced into the proximal fragment. With the straight cannulated reamer and sizing the canal, easily this 10 millimeter is going. And we are selected, which has got 2 mediolateral locking and 2 oblique locking. So this is the assembly which is assembled for the oblique locking, one from the medial aspect, one from the lateral aspect, and there are 2 holes here for lateromedial locking. So this we will be inserting now. This is how the distal engagement of the fragment will be there. As it is threaded, it will have good pulses and the rocking of the nail is prevented, because the distal part of the femur is bell-shaped with a wide medullary canal. So in that metaphyseal area, to prevent the nail rocking medially laterally, so this oblique locking as well as the threaded locking boards will help. So this is the lateromedial to locking, and this is anterolateral to posteromedial and anteromedial to posterolateral to distal locking. Yes. Now I'm passing the nail over the plain guide wire. The final few millimeters seating has to be done by firm blows. That I will be doing first. seating of the first screw. Done the proximal most lateromedial locking. Then I'm doing next the oblique locking. The next two. Then finally I'll do the lateromedial distalmost locking. So I'll do it the first this, next this one, and lastly the distalmost locking here. Happening afterwards. Am I? Chavi. Okay. Right. This is the next screw I'm using. 60. Yeah, 65. You give me 65. Yeah, fine. Incision with the help of the jig at 30 centimeter. I'm using the proximal most or the dynamic hole hammer. Save. Hmm? 40 millimeter bolt for proximal dynamic locking. Final wound after the closure, the entry side transpatellar approach, the oblique locking and the lateromedial locking, and this is the drain. Normally I keep a drain. This is the case of supracondylar fracture which we had treated 2 days back with multi-lock supracondylar nail. Patient at present is doing, and this is the static quadriceps exercise he is doing. Now he will do the knee bending. Gudga bakwa. Saral kara. Saral uchala. Saral karan uchala. Yes. Yes. So he is doing both knee bending as well as standing. Sitting by the side of the cot. Supracondylar nailing. Walking partial to full weight bearing with the help of walker comfortably at the end of 48 hours. Thank you. I never came for follow-up. Actually, literally, I had to send one of my assistant to his home and get him to get an X-ray done, but he did not come for an X-ray. This is only clinical picture. After 1 year, you can see. I couldn't get him. I couldn't convince him to come to hospital to get an X-ray as he was having no symptoms. This was a demonstration surgery done, the supracondylar fracture with the implant above, treated with a multi-lock supracondylar nail. Another polytrauma case, the supracondylar fracture was comminuted, so I treated this with a hybrid interlocking nail as well as a percutaneous plate fixation by the side. These are some of the steps of the surgery before passing the nail, and this is the percutaneous locking plate which has been augmented to as there was a lot of comminution. I keep the patient on knee frame. This is designed by Dr. Sanjeti sir. This is very, very useful. Getting flexion is difficult. So getting extension is not difficult. So I keep all supracondylar fractures on this knee frame in the postoperative period. And these are some of the follow-up pictures in the same patient. At end of 4 months, he had a very good function. And you can see at 7 months he is walking comfortably on the right side we have operated. So patient is able to walk in spite of he had a tibial condyle fracture on the other side. This is another case, multiple fracture neck, fracture shaft, condylar fracture treated with the supracondylar nail and a DHS by Dr. Amit Ajgaonkar. And this is the type of nail he uses. And this is at 6 months and this is at 18 months. You can see very good function in this. Some of the good indications for supracondylar nail is multiple fractures like this, which can be stabilized with one implant, or peri-implant fracture with a knee prosthesis or a hip prosthesis can be treated. Again, fracture condyle with shaft can be treated with a retrograde nail. Similar case again, fracture neck with fracture shaft can be treated with separately by 2 implant, neck with DHS and supracondylar with the implant. Floating knee can be treated with the same implant for both the fracture. Supracondylar nail can be used for tibia as well as the. To conclude, if I see a patient with fracture like this, my always preference will be to put a supracondylar nail. Thank you very much.
So that was the video demonstration by the IOA president, Dr. Shiv Shankar, on supracondylar nails. An excellent demonstration of that. And now the next talk will be by Dr. Gurinder Bedi, who is the head of orthopedic surgery at Max Hospital, Fortis Hospital in New Delhi. We have all heard him in numerous conferences, as rocking as this first picture that he has shown on his slide, and he's an excellent teacher. So over to you, Gurinder, for plating the distal femur.
Thank you so much, Chetan. I mean, I think it's been a great conference. I've been a very silent audience and I really enjoyed myself. So thank you so much for inviting me, and thank you so much for the other organizers. And very grateful to our Canadian counterparts. You guys have contributed immensely to at least my source of knowledge. And thank you so much for this. So I'm not as talented a surgeon as Dr. Shiv Shankar is, and I started doing plating a while back for distal femurs, and I've actually kept to it. Having said that, I mean, I'm not, as I said, not a great surgeon, but I still have trepidations whenever I see one of these. It's not one of the simplest fractures to treat. I've kept to plating because it seems to work reasonably well, but nonetheless, I think, when you think more and more about these cases, they are almost as good as any other mission impossible that you can think about. So just to start you off, there's a 56-year-old lady. She stumbled over a small step and falls over. So she's got this X-ray which she comes over. So when you look at it, you can have a look at the amount of comminution which is there. So that's the sort of trochlear area which you're looking at. That's the other fragments. You can see some cortical fragments lying at all sorts of weird places. You look at it, and I can't believe that you can't get palpitations just looking at the kind of thing that you need to assemble. So I do agree that that Mr. Couse here is known to do some very impossible things, but for me, this is as impossible as it gets. I mean, trying to put these fractures, mind-blowingly difficult at times. But fortunately, we're getting better at it. And I'll tell you what I do. I'm in the presence of an August company who's going to tell me more about it. So remember, we're talking about complex fractures. So here we're going to only talk about the C1, C2's fractures. So not going to cover every fracture because these are the ones which are really the problem. So these are the learning points we'll be looking at. So the first problem is obviously the problem that we're facing. And the issue with this is you're going to see a bimodal distribution. So you're going to see the young guy who's done a massive velocity injury. So he's already shattered it to bits. Or the other end is the very elderly who's got a weak bone. Although he's not got a high velocity injury, he still ended up shattering it into bits. So both ways, it's a difficult fracture. The other problem is the planes of the fracture, especially the coronal plane fracture, which are there. Many of them come out open. And to toss it all, as somebody used to say, well, you live a shitty life and eventually you die. So you go through all this and eventually you can end up still getting a non-union. So the current state of knowledge, which I'm not going to tell much about, we're all going to get a CT scans for this. We know that we need to get a a rigid stabilization done for the intercondylar part for the metadiaphyseal region. We're going to look at a biological fixation, a plate to bridge across, and we understand that majority of our people are using list plates for this, and more we're using the more extensile approach to get into it, and we pretty much, I think, on par with it. I understand you can do nailing. It's not something that I do very often, but nonetheless, these options are available. You've seen Dr. Shiv Shankar talk about it. What I would say is don't have just one thing on the table. Make sure you have enough small plates, 3.5 plates, headless screws. You need the kitchen sink with you when you go on to do those things. So this is one technique which is there, which is the R4 technique, which I think Christian Critic described well. Basically, it's a lateral approach. It's a lateral parapatellar arthrotomy. You go in through there. So this is what is a very good tip, because you will end up having to put screws outside the plate. Unfortunately, there's no template for this. So try making a template out of the plate which you have. Keep it there. Mark out where you're going to put your intercondylar screws, and you can do that right in the beginning before you start assembling the plates. Then you actually get on assemble the plate. I would really advise the use of this jig. It gives you that stability provided you actually lock proximally and distally. Don't start locking in between when you're fixing the jig. The jig is a tricky one, not 100% foolproof thing. So there you go. You're putting the intercondylar screws in there. You put them all inside. Once you have it, the intercondylar part is fixed. Then you can slide the plate just by the side of the vastus lateralis. You fix it with the wire. Make sure the wire is parallel to the joint line. Then you go proximally. You see the anterior border. You see the posterior border. Then you actually go right in the middle. But make sure you keep doing that. You don't need to make a big incision, but it's not the end of the world if you ended up making a big incision. Fix it proximally. Fix it distally. Check it out. Check it out loads of time. Check it out everything. You check your AP view. You check your lateral view. You check that the plate is lying. You check your fracture is reduced well, and there you go. So once you have this kind of a construct on, you can actually go ahead and actually fix up the rest of the bone. So more and more, the lateral parapatellar arthrotomy seems to work well, because very often there's an half-arch fracture. So you need to see the condyle, and you want to see it through this. So the extensile approach, also called as the swashbuckler approach, is what I use very, very commonly. You can use it as lateral to the lateralis, so you can split the lateralis. It all depends on the kind of fracture. This is the kind of exposure that you need to get if you're going to fix this, and this is what you would need to get if you have a Hoffa's element. You need to be able to see it clearly, so you can actually visualize it, pass your screws in, and you're just going to decide whether you're going to go from the front. This is not something that I've used at all, but it's there described in the literature. So here's a variation to this. So this was a 53-year-old guy who had an old problem in his femur. He only had a range of movement from about 15 degrees to about 45 degrees because of a childhood problem that he had with septic arthritis, a fracture which he developed. These were the CT scans that he came to us. So you can obviously there's a Hoffa's fracture in there, which you can see he's already got arthritis. He's got a very, very malformed kind of a thing, and when you look at when you look at him, he's already got this huge puckered up scar, which is there, which needs to be involved in sort of the incision. But you need to also get to this Hoffa's kind of a thing. The scar, remember, is a medial parapatellar. So here we opted to go for use the old incision which was there. Then he hardly had any bend, but we also ended up having a lateral incision and expose it from both sides, because we had to fix the Hoffa's on the lateral element. So that was the lateral incision that you can see is the iliotibial band. So you slit through the iliotibial band, you lift up the lateralis from the lateral intermuscular septum. Once you elevate it, it's all a scarred up tissue. So not the easiest of things. Remember, he's never really bent his knee that much. Once you've really done it, you put your finger back. You can actually see the Hoffa's fracture fairly well from there. So it's not what what we call as a native knee. So hence the difficult dissection that you can see us doing. But you need to visualize this sophos fragment. You also actually need to. We didn't have the range of movement to see all the way. So this is the suprapatellar, the supracondylar area, which we elevating the quadriceps off from the thigh bone. You can just about see the fracture coming in there, and you need to actually visualize it so you can reduce it from the side. That is the joint line. You can do a arthrotomy. You can take the meniscus out separately, just enough so you can see it. So this has got to be a massive exposure. You need to see the bone fragments, and that's the shaft which you can see. Until you can actually see it, you can put a clamp onto it, you can put a wire onto it and wire it. It really, really doesn't work. So this is much more difficult than the standard kind of a thing. And remember, there's no normal anatomy in this case that we're looking at. So the bone is now fully exposed. That's the shaft fragment. That's a lateral collateral ligament. You can see the stitches in there, which is the submeniscal arthrotomy. That's the Hoffa's fracture, which you can see in there, and that's where we start putting the KYs. Once we got this some sort of a malign, then we go on to the medial side. We went on to the medial side because it wasn't a sort of well-defined anatomy, and we realized that we would have to put a medial plate. Not necessary at all, but in this case, we thought we would need to put a medial plate. It's a very, very distal fracture, which in my books is an indication. So that's again the medial arthrotomy, which has been opened up along the previous scar, which you can see. I'm sorry, I've run it at a high speed because it's slow speed, you would really have wasted a lot of time going through it. So that's again the patella being lifted off from its adhesion side. And once you have a look inside, the trochlear fragment is the one which really annoys you, because you need to visualize that's a trochlear fragment which you can see, and is difficult to reduce at many times. Again, lots of KYs, fix the condylar fragments to each other, fix the condylar fragments to the diaphysis. That's the end result. I know it's not a normal looking femur, as I said, but a dual plate in this was something that you need to think about. So the plan of attack, always go for a direct reduction and absolute stability in the intercondylar fragment, and then you put an indirect reduction, relative stability, whether you use an external fixator or whether you use a femoral distractor. All of these work quite well in this. So this is another example where you got the clamp, you got the intercondylar fragments fixed up, then you you put a wire across, then you got a plate. Remember, you got to stabilize it first. Use the anatomical configuration of the plate to stabilize it distally. Use that to get you the alignment. You do not have to push the plate onto it. So that's where we talk about complications such as the golf club deformity, and also that's just the plate being brought about because there's a butterfly fragment. But not for a moment would I say you've got to press the plate against, and that's fairly crucial thing. There are variations to the scheme, and we know that the medial column combination, the coronal fracture, and the Hoffa's fracture is well known. I think all of you at this level would have read about this paper by Nock and Sagina, which talked about the fact that about 1/3 of them have a Hoffa's fracture, and if you don't do a CT scan, you're going to miss out the majority of them. So always get a CT scan, but always be suspicious of this. This is what you would kind of approach you would need to do, in which you can see the Hoffa's fracture fairly clearly, even with this again. So this is a plating which we need to be done. So do you do both the column fixation or you don't? Well, the simple question somebody asked me, why would you always do it in the humerus and not in the femur? I really still don't know the answer, but I don't do it all the time. When do I do it? I do it whenever I think my distal fragment is too small. I would always do it in a non-union. I would always do it in a periprosthetic fracture. The other test that was described was you fix your lateral column and you see if by giving a stress, the medial column is opening up in front of you. That's some of the literature which came about it. If you can see mobility at the medial column, you should go ahead and fix it. Plate which you should use the proximal lateral tibial plate. Is a paper which took that as the best hold that you could think. What happens when things go wrong? So as I said, you live your life and then shit happens, kind of a stuff. So huge incidence of malunion, huge incidence of non-union, high incidence of malunion, a lot contributed by the kind of plates and all we're using. Huge incidence of non-union. In fact, some people thought this was a non-union producing plate actually, and there were lots of papers which looked at it, which got printed in Journal of Orthopedic Trauma. So these are the ones which are the factors which I've identified. So steel plates always stand out in the three papers which looked at it as one thing which actually causes a higher incidence of non-union. So if you're using a list plate, a titanium is a better steel. So these are some of the figures which are quoted. Non-union is fairly important for every reason. One, it contributes to non-union. Second, it actually contributes a lot to the post-op arthritis developing. One thing that gets seen very often is this valgus malalignment, and that's an example of a valgus malalignment. If you try to just reduce the plate onto it and your screw is not parallel to the joint line, you are going to produce this kind of an opening on the medial side, and that's actually going to cause a bit of wear, awkward wear, and even a high chance of union. So what happens if you put a plate too anterior or too posterior? So if you're too anterior on the shaft, you're going to miss it. It's going to be unicortical kind of a stuff. If you're actually too anterior on the condyle, you're going to rub the lateral, the tensor retinaculum. And if you remember, the other thing that happens if you're too posterior, you're not on the convexity of the lateral condyle. So you're actually going to produce a golf club deformity because you're actually not contouring the anatomical plate on the anatomical prominence on the lateral aspect, and you're going to push the plate. So here's an example of a plate which wasn't really put properly. So this is a demo, obviously, and you can see that the plate is too anterior, the screws will be too small, and they will go to the patellofemoral joint. Yeah, the thing that I was making a point was, make sure you actually put your plate anatomically on this. Don't have it standing out. So if you have a standing out, you're actually predisposing yourself to developing what's called as a golf club deformity, because you will rotate the shaft to the condyle when you try to fix this up. So you need to tilt your plate to this, and this is going to cause a problem if you don't get it right. If you're too anterior, too posterior. So this is an example of a too anterior kind of a plate, and you can see the screws going in all sorts of wrong direction. So in fact, even exiting at the back, going into the notch kind of stuff. And if you go into that, then you're obviously going to impinge on your anterior cruciate ligament. Too posterior, remember I said you start producing the golf club if you're not aligned with that prominence. Again, this is an example which shows what happens when you're too posterior. So the screws going into the notch if you're too posterior. And you can actually cause, so when you, and the anterior aspect of the plate is getting a unicortical kind of a stuff. If you're too proximal, again, the alignment doesn't happen. You see it, you can actually see it when you're using an image intensifier as to how bad the plate is. If you're going to be too distal, you're going to produce that valgus kind of a deformity there, and you will open up the fragment on this side. So remember, everything, the plate is actually there to help you out. Yes, fix it well, but you need to realign it better. So that's what happens when you put the plate too distal. You're not getting enough screws, not getting enough purchase. Very tempting when you have a very distal fracture to push it more and more distally, but it doesn't really work. Rotational deformity, again, a big thing normally happens when you actually don't put your plate flat up against the condyle. So it's actually lifted off from there, and the screws are actually not going in the right direction. And remember, you're producing a rotational malalignment. Again, lots of names given to it. So it's not going to be a fairly good construct, not a stable construct. So you need to make sure that you align your plate well. This is the only area where you're actually going to get the plate and screws if you're going to align it well. So you need to reach into this area of the shaft. You do that if you're not too anterior. This is one plate which is applied too anterior, and the moment you tilt it slightly, the screws start to go into the intercondylar notch. Procurvatum, recurvatum, huge implications on the gait. So very cautious when you're doing that, and it's very common, very common. If you leave it too far off the bone, too huge a cantilever effect, too much of a torque, high chance of implant failure. So here things which go wrong. The plate is obviously too far out. It's a it's a varus kind of a reduction. You can see the opening up on the middle side. So huge attempt made to try to fix it. Obviously, surgeon tried very hard to do something, but obviously it failed because never really going to work. So this is what's called as a golf club kind of a deformity where you actually lateralize the shaft and medialize the condyle because screws were really squeezed in onto the squeezing the plate onto this. And again, an example where there is a valgus deformity which has been produced because the screws did not go in the right direction, and obviously there's a procurvatum deformity which is produced, and the screws are not in the right direction, being too low, obviously going into the notch. So these things are all sort of staring at you on your face, kind of a stuff. So you need to look out for that. You need to be careful about this. It's not just the fracture. Putting the plate is a huge thing. These are some of the things which we worked out at predictive factors for non-union. Just finishing off with this lady, which we did. So this is the post-op X-ray that was produced for this lady. So 2 months down the line, the comminuted portions are still hanging around in the air. 5 months again, nothing happens. 6 months, nothing happens. 8 months, nothing happens. You get a CT scan, you can see none of these areas is getting filled up. So then you go in there, you put a graft and you put a plate, and eventually it took 1.5 years to join. So it's a difficult fracture, mission impossible, yes, but still achievable. Basic principles still paramount. Need to fix the condyle, fix the articular surface, have everything available for you. In my opinion, expose wide. Expose wide. You're not going to get it through small incisions. Long plates work. And again, same principles always will work. Thank you so much, and thank you so much for inviting me.
Thank you, Gurinder. That was an excellent talk covering almost everything about the distal femur plating. Thank you very much.
Thank you.
I don't think there'll be many questions. There's one question for you though. If the femoral bow is more, how do you manage proximal plate positioning?
That's actually
so. I also wish to ask you about the plate length. So, what's the appropriate plate length, and how do you manage the femoral bow?
Okay, so there's a zero doubt using bigger and bigger plates, as I think all of you, and more the combination, the bigger the plate that you use, because you're going for a relative stability model. So you need to get about 4 to 5 good screws in the shaft. To get 4 to 5 good screws, giving an alternate screw configuration, so you're looking at about a 10-hole plate, just about as the bare minimum to use, because 10 to 12 hole is what is going to be our bare minimum plate. The femoral bow is a real problem, and I think I've tried to get around by using cortical screws, which is not what I really want to do, but I ended up using cortical screws and try to do. I don't have a good answer, Ketan. I've struggled with this. I've seen my plates looking terrible in the operation theater, but the only thing I've used is switch from a locking to the cortical screws. I don't know if you have a better option for that.
Another question is, when do you use locking screw in the proximal part of the plate, or when to make construct more rigid than in osteoporosis? So I think it's pretty clear on this that you don't use all locking screws in the proximal portion. You make it more elastic kind of a fixation. Anything else you wish to add?
No, that's it. I mean, I would have at least about 3 locking screws in the proximal part of the shaft, at least 3. And I would use that one kind of one at the top end or something, or one a slightly tangential cortical screw at the top. 3 of them will be locking screws for me.
What if you get a grade 1 or a grade 2 open fracture in such combination? What is your preferred management? Another question from the delegates.
So for me, there is no answer. I mean, the external fixator does nothing for me in terms of a temporary fixation or something. In fact, I would say that even to a grade 2 or a grade 3 also, I'm going to go ahead and operate and put a plate and do everything. Only thing I'm going to add to this is, that those areas left in between where the bone is too comminuted, which it invariably turns out to be, they're all high velocity injuries. I would happily put like a masculine, even with sometimes with the close you've done the masculine kind of thing, put in a block of cement, come back and do it. The masculine kind of thing works in magic. Closed or open, it doesn't matter. For some of these difficult ones, try that. It really works very well. So 2-stage surgery, but definitive fixation at the first time.
Great. Yes, so that is all. Thank you so much, Gurinder, for that excellent disposition.
Much
So next, we move on to the proximal tibia. and to enlighten us about technique of lateral condylar fixation with a submeniscal arthrotomy. I invite Dr. Rajiv Rai Chaudhary, a senior teacher, a senior orthopedic surgeon from Surat. We have all learned from him at various courses, and he is a teacher par excellence. So over to you, sir. You can share your screen, sir.
Thank you very much, Dr. Parag Chancheti, Chetan, Atul, all the scientific committee chairman for this invite. When the topic of bicondylar fractures was given to me, I thought it was too big, and I'm not as good as Gurinder to cover everything at a very fast pace and cover the whole topic. So I've got a short video that demonstrates how to elevate the lateral condyle. It's a submeniscal approach. And the second part of my presentation is the tibial tuberosity fragment in a bicondylar fracture, which is relatively less emphasized in most scientific deliberations. So this is a 45-year-old patient presented 5 days later with a depressed fracture of the lateral tibial condyle.
So we cannot see your slides yet.
You cannot see the slideshow.
I am, just a second.
Is it opened on your screen?
It is it says, shall I go to new share? No.
Yes, sir.
Yeah.
That's seen. Is it seen now?
Yes.
The video is seen, sir.
Yeah, it's the video at
Yes,
the moment.
yes.
Yeah.
Seen.
Yeah, I'm sorry about this. So just to repeat, so this is a 45-year-old male with a depressed fracture of the lateral tibial condyle, as it is seen in the CT scans, very, very clearly seen in the sagittal plans. And this is the operative video with the tibial tuberosity marked. That's the shin of the tibia, the patella marked above. We have the knee joint that I would mark up here, as you will see, and I'll also mark the fibula so that it remains my lighthouse. I see the fibula to know how much of my fragment is lying posterior depending on the CT scan. So 1 finger breadth lateral to the shin of the tibia, I take a curved incision and take it a little up. So I just cross I go on my incision, skin incision line, and here you would see that I am now looking at the Gerdy's tubercle where I would do sharp dissection. So that's my Gerdy's tubercle, and I'm coming up to the joint where you can see a hemosynovial bulge, if you can see that. Very clearly seen, that's the presence of the joint up there. Now I take a full thickness flap and dissect it a little posteriorly. This is sharp dissection, and I at the same time do a subperiosteal elevation of the lateral surface of the tibia. I do a sharp dissection anteriorly as well, where I'm lifting a part of the iliotibial band. And at this stage, you can see the hemosynovium very clearly. And I take an osteotome and I take a small, thin sliver of bone so that when this closes, I get a bone-to-bone contact and a better fixation. So that's my osteotome a little anteriorly. Takes a very thin sliver because it's already fractured. I don't want to increase the comminution in that area. It's a very sharp osteotome. A part of the anterior part after the osteotome is again sharply dissected. And that's a sliver of bone from the lateral side. I'm cutting the meniscotibial ligament, hugging my knife just close to the superior surface of the tibia, so I do not inadvertently injure the meniscus. Now, following this, I would lift the split fragment anteriorly, as you see. Occasionally, I would do the same posteriorly. You can see a lot of clots, and this is being irrigated. The hand has been put not to hide anything from the delegates, it's only so that nothing comes in. You can see one or two pieces of. Now, there is a hook that has, it's a tendon hook that pulls the lateral meniscus, and I put 2 or 3 stay sutures depending on the size of the fragment and the amount of opening I need. So that's my stay suture in the, so this is a submeniscal approach. You can see very clearly that the meniscus has gone up. And for the sake of time, I've put 3 sutures here. There was a small fragment of articular cartilage that was shaved off. You can see the inferior surface of the meniscus there, and you can see the depressed fragment. Now, depending on the size of the fragment, you can see that is gone inferiorly to quite a large extent. I now elevate gradually, either with a large osteotome or probably a Couse elevator is also a good instrument. When I do this, not shown in the video is that a varus force is applied by the assistant to open up the knee as much so I do not undercorrect my elevated fragment. So you can see that with one hand I've got the Couse holding and a K wire. I'm going to put 2 K wires that temporarily hold my reduction, and these K wires come on the opposite side, which I will pull out from the opposite side, so the wires do not interfere with my plate positioning later on. So here we are. The wires have been pulled till the edge of the fracture fragment. And the golden rule is you can never, ever overcorrect your tibial condyle fracture. At this stage, I'm putting the threads from the stay sutures in the meniscus into the plate. I've got my area ready there, and I'm using synthetic bone substitute filling the defect. Once I've put these, I would use a punch to jam pack the defect. You can see it's a very large defect, and this is about this is a 10-gram packet of the tricalcium phosphate crystals, Chronos. And there I am punching it, because deep inside I will need a narrow punch, and as I come more peripherally, I'll need a larger size punch, as you will see a minute from now. So that's a large punch. Now I put my plate, I have the superior part of the tibial condyle where I put my finger, and I temporarily hold the plate with K wires, one K wire distally as well. So you can see a lot of calcium triphosphate crystals and a fairly good reduction. The first screw I put is in the oblong hole. And following this, I make a hole in the proximal fragment, the proximal screw on the sleeve, and then use a pointed clamp to compress the fracture, following which this is fixed. I mean, sequentially, screws are put in, and as you will see, the sutures of the tibiomeniscal ligament are tied to the plate, and finally closure done. So that's the final X-ray, and I would finish this part of my presentation, go to my next small slide presentation. So the aim of this part of the talk is to highlight the less emphasized tibial tuberosity fractures associated with complex tibial fractures.
We can't see your slide show again. I think you have...
One second. Can you see now?
No, we can see the old last X-ray of your video presentation. I think close that first.
One second. Stop sharing.
Close the video, sir.
Yeah. Can you see it now?
Yes.
Okay, good. So can you see my slides now?
Yes, we can.
Thank you. So this talk will aim towards highlighting the less emphasized tibial tuberosity fractures, see what are the strategies, what approaches, reduction tools, and implants should be used to fix this fracture. Of course, we'll talk about rehabilitation as well. Now, one must remember that the tibial tuberosity fracture is equivalent to the disruption of the extensor mechanism of the knee and should be recognized in the preoperative evaluation so that it can be incorporated into the surgical plan. Surprisingly, the Schatzker or the AO classification have not included this fragment as a part of their classification. Well, usually these fractures associated with the tibial tuberosity fractures are a result of high velocity in injuries. This particular fracture requires some special thinking with regards to what approach, what fixation, and what post-operative management should be incorporated in the planning stage. The incidence varies between 15 to 30% in various series, the average being about 20%. Why is it missed? Because a poor lateral X-ray can miss the fracture. And the other most common thing is the surgeon is so much distracted by the displaced huge number of the blowout of the two condyles that the little tubercle just goes out of sight. If neglected, it could lead to a non-union of this fragment, leading to either an extension lag or lack of active extension of the knee. So the fixation should be performed at the time of surgery, but after the two condyles have been fixed. One must remember to protect the soft tissue envelope during the exposure and placement of the fixation, as the soft tissue is already compromised. On a plain X-ray, there is a we look for. But of course, the CT scan is indispensable. That always gets you the diagnosis. Whenever the lateral condyle is injured, usually one can approach this tibial tuberosity fragment through the same anterolateral approach. But occasionally you may use a percutaneous approach to fix screws or a small anterior approach for reduction of the tibial tuberosity and fixation with a small plate. What to use? The fixation is usually either by screws alone or by a screw and a plate. So what to use when? If it is a single large fragment, a couple of interfragmentary screws are adequate. But if there is small comminuted fragments of the tibial tuberosity, or there is comminution of the posterior cortex, then usually a plate that would serve to increase the surface area is used. The plates used usually could be either a 1/3 or a 1/4 quarter tubular plate, mini fragment plates, or 3.5, 2.7 screws or tension band. Reduction tools would include pointed clamps, ball spike, push-up spikes, or dental pick. Always remember, if there is comminution of the posterior cortex, a plate is kept and the distal screws are inserted holding both the cortex, thereby they are buttressing the tibial tuberosity fragment. So the algorithm will be that if there is a tibial tuberosity fracture, look if there is an intact posterior tibial cortex. If it is intact and is a single fragment, in such a situation, you just have to put individual screws, and that should be all. Now, if there is a posterior deficient cortex of the tibia, proximal tibia, or the tibial tuberosity fragments is in multiple pieces, then one uses a screw and plate, and the choice of implant have already been discussed. Now, as far as the rehabilitation is concerned, one must remember that although continuous passive motion is started as soon as the wound has settled, say in about a week, 10 days time, before which a knee immobilizer is used. But active flexion, although permitted, active extension should not be allowed for at least 6 weeks. So for 6 weeks, no active extension, and non-weight bearing for about 10 to 12 weeks. So a few cases, and here we see that this is a tibial tuberosity fracture. There is posterior comminution, and it's a 36-year-old lady, and here we have managed to come out fairly well with a couple of screws. So this is an example where 2 screws have been used to fix the tibial tuberosity fragment. Now this looks a very innocent X-ray, but when you see here, it has a separate tibial tuberosity fragment, and this has its large fragment. The posterior cortex is intact. 2 screws have been used to fix the tibial tuberosity fragments. And those are the post-operative X-rays. Now this is a 50-year-old lady, comminuted tibial tuberosity, comminuted posterior wall. In such a situation, the plate, after fixing the 2 condyles, a plate through the anterolateral compartment incision has been placed. Now, if you see that one of these screws is oblique going up, and the reason why it's put like this, because there's severe comminution posteriorly, and there are 2 screws that are holding the 4 cortices, holding the plate, and this has been molded so that there is less of hardware irritation. So that's the X-ray at 1 year. Another patient, open tibial condyle fracture, and here we can see that there is a comminuted tibial tuberosity fragment. Now, because this was compound, a vac was put, initial debridement, spanning X-fix, there's some swelling, and after everything's settled, you would see that a 1/3 tubular plate has been used here to fix the tibial tuberosity fragment. Again, this has been done through the anterolateral approach, so the approach remains the same. The screw, oblique screw here, is a lag screw, so the multiple pieces that were there have been buttressed and lagged. So to summarize, look out for and stably fix the tibial tuberosity fracture in complex proximal tibial injuries. First fix the condylar element and then fix the tibial tuberosity fragment. Although the anterolateral approach is commonly used, a percutaneous or a direct anterior approach may be required. The strategy depends on the combination of this fragment and or the combination of the posterior cortex. If individual screws have been used, do not forget to countersink the individual screws to prevent hardware irritation and rehabilitate carefully. Thank you.
Thank you, sir. Excellent video and a very useful talk at the end of it about the tuberosity fractures. As expected, no questions because everything was quite nicely explained. Thank you very much.
Thank you.
We move on to the more difficult coronal splits in the tibia. And to talk about posterolateral and posteromedial fractures, I invite a very close friend, Dr. Jignesh Pandya, once again from Surat, who will be showing us how to do them. Over to you, Jignesh. He's a very dynamic senior surgeon from Surat. Again, an AO faculty on many courses and expertise in lower limb injuries as well as joint replacement. Jignesh.
Yeah, thanks a lot. Can you hear me?
Yes.
Can you see my screen also?
Share your screen, please.
I have already shared. It's not there?
No, we can't see your screen.
Okay, I will try.
Not seen yet.
Can you see?
Yes, now we can.
At the outset, first I am very much thankful for opportunity to have such a platform presentation, my talk, and I am very much thankful to you for this opportunity. My topic is posterior column fractures. It is a posteromedial and posterolateral condyle of tibia. So there are three things in this. One is posteromedial condyle isolated. One is medial condyle mimicking like posteromedial condyle, which is posterior apex or a double apex. Third is associated posterolateral condyle with posteromedial condyle. And fourth is isolated posterolateral condyle. So all the four things I am trying to cover. I will put up a video for extended posteromedial condyle and I will put up beautiful pictures for posterior condyle as time will not permit me to present a video. So let's start with the medial condylar fractures first. Learning objectives from this talk will be identify medial condylar fracture and understand fracture geometry. Associated injuries like ACL avulsion, PCL avulsion, and associated posterolateral condyle, and change your treatment plan and how to fix posterolateral condyle from the extended posteromedial approach. We'll see the video of that. So first of all, I will say understand the fracture. This is a medial condyle with posterior apex fixed from anteroposterior lag screw, and you can see the result. This is again, there is no screw in the proximal fragment. The plate is very much down for a medial condyle posteriorly. Another X-ray of medial condyle with a posterior apex, and this is a wrong plate at a wrong site and wrong surface. So it will give a bad result. So these three examples say that we have to understand the fracture geometry properly to get a perfect outcome. Now, this classic posteromedial condyle fracture, if we want to address it in a bicondylar fracture with a lateral plate, none of the lateral screw rough screw cannot fix this posteromedial fragment, not possible. If you want to do lag screw from anterolateral to posteromedial, the screw will never pull the fragment. So it cannot be lagged. So lag principle is not applicable in a posteromedial condyle. What is acceptable to this is buttress principle. How? This is the way you reduce direct approach, reduce 100%, put a plate, first screw at the apex and then rest of the screws. That will make it 100% like this. If the plate will be like this, first screw at the apex, and you can see the posterior buttressing perfectly well, doing a good fixation of the condylar fracture. So this is a posteromedial condyle, and you follow the arrows. So this arrow are showing the coronal plane posteromedial condyle. Associated intercondylar amino fracture and small fragment of PCL is there, which is not much displaced. So it needs only isolated fixation of the posteromedial condyle. There is some impaction of the posterolateral condylar fracture, but it doesn't need elevation and address. So these are the fractures we have evaluated, and direct posteromedial approach and a small T buttress plate. This is a 3.5 millimeter radius plate, which is fixed, and the plate which is fixed directly on the posterior surface in a PA plane and not in a mediolateral plane. So you can see that cannot work in a shear fractures posteriorly. Now, this X-ray, in lateral view, you can see some spike, but in AP view, there is no fracture. But suspicion is the best diagnostic tool. So if you get a 3D CT, you will see complete medial condyle fracture with posterior apex, ACL avulsion, and posterolateral condyle impaction. By and large, in all the medial condylar fracture, you will see these two elements together, ACL and post. They are good close relative of this injury. Isolated posteromedial condyle is a rare injury, rare. ACL is very, very commonly associated. It is 92% incidence, either substance or it is actually a fracture subluxation or dislocation. It cannot occur in solo. So this is how it was addressed from posterior approach, apex plate, a screw at the first screw at the apex, and then plate fixation and perfect elevation and good outcome of the fracture. Now we will see these two types of the fracture: medial condyle with either posterior apex, total medial condyle with posterior apex or a double apex, and impaction of the posterior condyle. Associated ACL may or may not be there. By and large, it is there. Another variety is posteromedial condyle with posterior condyle. So it makes a posterior both column fracture injury. And this needs a separate assessment and evaluation and planning for the treatment. Both the fractures need separate assessment. We will see examples of both the cases. Now this is an example of posteromedial condyle with posterior condyle with ACL avulsion. This is classic case of coronal plane fracture of both the condyle posterior. This is varus flexion force injury with posterior subluxation of the tibia. It's like a Bowler-Barton fracture, you can say. So what we will be planning? Reduce posteromedial condyle by extended posteromedial approach. Put a plate, first screw at the apex, then rest of the screws fixing the posteromedial condyle. Then unless you fix the first posteromedial plate, you cannot do anything to posterior condyle from this approach. So you get the shaft back posteriorly on the condyle, and then you can see the posterior condyle in front of your eyes. We will see in the video. And then elevate posterior condyle and put a buttress plate with screws to proximal to distal enough. And this is how it was done. And ACL was separately fixed from anterior approach by transpatellar incision with forward screw. See, this is an example of video. This is a case showing round circle is following posterior condyle. You can see impaction and depression of posterior condyle. The green arrow is showing posteromedial condyle, again with ACL avulsion. This is classic posterior bicondylar tibia fracture, and ACL is always there. So this is the video. Prone position, left side thigh, right side calf. I am taking a curved incision. The horizontal crease is a popliteal crease, and I have curved the incision about 1 inch proximal to it, and cut skin and subcutaneous tissue. You may get some vein there in subcutaneous plane. Cauterize it. It is edited video, so we will go one step by step. Now I will go to deeper plane. Proximally there will be fat pad, and in that fat pad you can palpate semitendinosus. So if you take a deep incision without palpating, you will cut the semitendinosus. So palpate. My finger is palpating semitendinosus. So there is a plane proximally between the semitendinosus and medial head of gastrocnemius. Now you are to run your finger under the gastrocnemius and elevate and create a plane between the gastrocnemius and popliteus muscle. We will see popliteus muscle in the floor. Now you can see the popliteus muscle in the floor. I have put a spike anteriorly over the anteromedial border of the tibia. Just have a proper recording of the video. Otherwise, you don't need to put a spike there. Now start cutting the popliteus muscle from the posteromedial border of the tibia. You put your knife deep and should touch to the bone. Knife should touch the bone and cut completely in one line, whole muscle. So you are elevating the origin of popliteus muscle from the tibia. So cut all the muscle fibers with knife only. You use periosteum at the end, otherwise it will make it chunda. It will get crushed, the muscle will get crushed. So you cut all the fibers sharply as you are elevating the pronator quadratus in the wrist with knife. Okay, so this is what we have cut. Now we will cut the proximal part, which is tendinous portion of the origin of the popliteus muscle. So cut with the reverse knife. Go on palpating the fibers. As you go from medial to central part to cut the tendon, you cannot elevate this by periosteum. So you have to cut it with the knife. But be careful, you identify the fibers attached to the tibia and cut it. In central portion, there will be vessel very close to it. So if you go in center without watching properly, you can nick the vessel. But if you are safe, careful, then you cannot cut it. Now I have released that muscle. Now you will see complete release of the origin of the popliteus muscle, and that is the tendinous portion. And you will see vessel. I will show the vessel. It will be lying between the gastrocnemius and popliteus muscle. It is very safe. Till you are reached to the bone and stay on the bone, underneath the popliteus, you cannot damage the vessel. Very safe. Now, step of the cutting and releasing the middle half gastrocnemius tendon. So just cut the tendinous portion. Don't cut the muscle. Your knife will ease your finger. You palpate the tight portion of the tendon, retract it with the retractor distally, so it will become tight, and just release the tendinous portion. You can get the release. And you palpate the finger, there are no fibers of tendons are left, and your muscle will be retracted to almost half of the condyle. And you will be able to see the posterior part of the condyle. Now, the third step of the procedure, you are releasing the soleus muscle from the soleal line. You can see the tendinous portion and cut in a reverse manner from distal to proximal. Don't go from proximal to distal. If you enter the muscle fiber, you will cut the posterior artery. So you cut by palpating with knife on the bone, keeping on the bone, on the subperiosteally, all the tendinous portion of the soleus muscle. The moment you release it, you are king on that surface. You can put your spike safely there, and your vessels are flying high, cannot damage the vessel. You are under the popliteus muscle, under the soleus, and you can safely work on the posterior condyle also from the same approach, and you will be able to see posterior condyle very nicely in front of you. With this release approach, you can see 85% of posterior surface of the tibia, and you can go up to upper two-third or up more distal to the tibia if you want. Extend the incision distally, and you are very safe on working on the posterior surface of tibia. Now we will see the posterior condyle. How you can see whole surface of the tibia posteriorly. And I am just elevating the condyle just to demonstrate that this is a fracture. It is simple fracture. So reduce and fix with the simple T plate. You can use posterior anatomical plate also, depending on the size of the condyle and requirement. And my suction is in posterior, joint, posterior condyle in the knee joint. You can see the articular surface depressed. So this is how you can see. You can see under vision, you can elevate it, you can use a feeler, and you can put a second plate there. So that procedure is done. After putting the plate, I will go for closer, and you can see whole complete muscle of popliteus, which is covering both the plates, and vessels are very safe over the popliteus muscle. These are the vessels. This is a picture from another case. So again, you can see two plates, same approach, same way it was done. Now you can see another case, two plates. It's very big series. I have a number of cases like this. And you can see popliteal vessel with tourniquet, you can hardly identify the popliteal vessel. But without tourniquet, you can see the vessel how it is bulged and it is lying on the popliteus muscle. The only thing is when you release the tourniquet, the wound field should look like as if tourniquet is on, except you will have a bleeder of medial genicular artery or some of the perforators in the medial side. Otherwise, no major bleeder. If any major bleeder is there, probably you have punctured the popliteal artery. There are no bleeders in this approach if you do a perfect in a plane. So this is the closer, and you can see pre-op and post-op X-ray with 2 plates posteriorly and doing a good fixation. Now we will see total medial condyle with dual apex, and you will see this is a AP view CT scan, medial apex. Posteriorly, it is a posterior apex, and ACL level is there. Very small impacts on the posterior condyle is there, and you can see 2 arrow. Red arrow is the medial apex, yellow lower down. Yellow arrow is the posterior apex. So if you don't fix this total medial condyle in 2 planes, it is going into varus. So this we will see a lot of accidents like this, that somebody has done good posterior plating, but the tibial condyle is in varus. What happens? So it should be first posterior approach, posterior approach. Put a apex screw. So reduce posterior apex first, but don't put any proximal screw. Correct the varus in a mediolateral plane. See the condyle. It is a cone-shaped condyle. It has cone posteriorly and medially little bit smaller, but the whole condyle is wide upper and it is intercondylar fracture in proximal part. And distally, it is a medial condyle fracture. In triangle bone, it makes 2 apices. So you put intercondylar screw and then rest of the screws. So this I have put first screw, and you can see the PA view of the C-arm. There is a varus. Red arrow is there. I have corrected the varus with a joystick and put intercondylar screw from lateral to medial. Why lateral to medial? I will tell you. Then I compress the frag first and then put the rest of the proximal screws. This is post-op X-ray, and you can see there is no varus, 100% reduction. Lateral to medial screw has the advantage of having thread in the medial condyle, which we want to fix. It is a smaller part. If you want to put medial to lateral condyle screw, then the thread will be in lateral condyle and medial condyle will not have much of the hold in the screw. Second thing, medial to lateral screw will compress the MCL or damage the MCL, and it will irritate and patient will have difficulty in flexion. So it's better to put a screw from lateral to medial side. You may put the wire from middle to lateral, but put the screw from lateral to medial CC screw. It can be 6.5 or 7 mm screws. Now this another variety, total medial condyle with post-rotator condyle depressor. Similar fracture which we saw previously, and it has but additional post-rotator condyle with ACL is there. Now again same way, distal screws are fixed, joysticking is done. You can see follow the images of IITV. Second image showing the correction of the varus and put intercondylar screw. Then after fixing intercondylar compression medial screws, I have gone to posterior condyle. Second plate is fixed, elevated, grafted, and this is 3 years follow-up in full function and perfect reduction maintained. So we have to understand this type of the fractures. When there is a coronal split in the posterior tibial plate fracture, look for a depression or split in the posterior plate as well. Mostly it is there. Keep the knee extended during posterior plate reduction. Isolated posterior condyle is a rare injury. Associated ligament injury, ACL, PCL is the rule rather than exception. Medial condyle fracture is the part of fracture dislocation injury of knee occurring due to varus force with posterior shear in a flex knee joint. CT scan with 3D reconstruction is the most important diagnostic tool to understand this injury and planning your treatment. So now we will go to posterior condyle. We have to do something different to change the outcome in this type of fracture, because this is a fracture in the corner of the condyle, posteriorly and behind the fibula. So it's very difficult to address this area. But if we don't do anything different, then we cannot change the outcome in this fracture to get a better result. So see this X-ray. First, it is difficult in diagnosis. Posterior condyle fracture depression is hardly appreciated in X-ray. You see the X-ray and now you see the CT. How much depression is there? It is totally condyle, posterior half is depressed and thrust with impaction of the posterior cortex. So it is actually split depression fracture like anterolateral condyle. Now, if we treat it properly by direct approach, we can get a good functional outcome like this. So why we should take direct posterior approach? This is an animation image. This is a coronal cut of the section of the fracture posterior condyle. Anterolateral, there is no fracture, but somebody wants to go from anterolateral side. One can go, definitely one can go. We have to break one more column, open the whole condyle, go posteriorly. We can hardly see the posterior articular surface, and still we can do indirect elevation under TV guided IITV guided reduction. And then we can put a lateral plate, put screws. None of the screw will buttress this fragment, and it will go for secondary collapse later on. And if you put a bone filler, it will come out posteriorly as there is no posterior cortex intact. So direct reduction and fixation of the articular fracture will be there. Will be there. Bone grafting and substitute filling will be easy from direct approach, and sub-control screw placement can be there like this. You can see in this picture. So direct support, how it works. You can see the direct approach and articular surface like this in front of your eyes. You can elevate it. You can put a filler and buttress all the screws underneath the fragment. So you are 100% sure, you can mobilize confidently that it is not going to collapse. And you can see on bone model, posteriorly plate exactly by the side of the facet for the attachment of the fibula. You can see lateral view, how it is contoured and placed high, and end-on view, where it is fixing it very well. So this is how the plate placement and how it looks like in the X-ray or IITV. Now we have to have an understanding of applied anatomy to be understood in this small window, but it is enough window to fix this type of the fracture. And there is two structures to be identified. One is a lateral popliteal nerve. It is in the approach, but not in the field. So it is in the approach. You have to just identify in the approach, but not in the field. But anterior tibial artery, it is in the approach as well as in the field. So what danger is the artery? If you don't identify and take care, you can damage or avulse the artery, and you can get some bleeding there, and it will be a problem on table. So it's better you identify the vessel very nicely and slide the plate underneath, because you have got only 7 centimeter window to work from articular surface to the artery, and you have to have one screw distal to the artery, retracting it, putting the in the plate, even in a 2-hole plate or 3-hole plate. So we go for example, and it's a beautiful pictures. 21-year-old female got this injury. It is a 20 millimeter depression of the lateral condyle fracture with a split on the posterior condyle. Let us see the CT scan. These are the CT scan, split depression fracture of the almost whole of the condyle, but facing posteriorly. You can see that. And there is no fracture in anterior cortex or lateral cortex. So these are the 3D CT images. And everything, all columns are intact except posterior column with the depression of the articular surface. So this is a prone position. Left side is thigh, right side is calf. Incision is just behind the head of the fibula, crossing the crease 1 inch approximately and 3 to 4 inches distally. Take a bigger incision, so you don't have to retract much. Cut skin and subcutaneous tissue. In thin patient, be careful, don't cut boldly, you can cut the nerve very easily. It is very, very close to the subcutaneous tissue than you believe. So be careful when you put cut skin and subcutaneous, don't incise the fascia. You identify the nerve underneath the fascia by rolling underneath your finger. And so my forceps is pointing towards the nerve underneath the fascia. Then cut the fascia distally in the incision and run your finger along the cut, and it will separate the nerve directly, easily, without using any artery forceps dissection for this nerve. If you handle it, you will get palsy. If you see it and don't handle it, you will not get a palsy. So this is how, this is lateral gastrocnemius, and that's common, that's common peroneal nerve. So interval between the nerve and the muscle, once you retract the lateral gastrocnemius medially, you will be able to see soleus muscle in the floor over the posterior surface of the head of the fibula. That is the soleus muscle. We have to erase the soleus muscle from the head of the fibula posteriorly, subperiostally, making the fibula head white. Don't enter in the muscle fiber, you will get a bleeding. So just elevate the fibers completely from the head of the fibula, and you will be able to put a spike under the muscle fibers on the medial border of the tibia, and you will be able to see the fracture completely. So this is where we have reached the fracture. Now you don't have to take the nerve or isolate the nerve with rubber band. You see, nobody is retracting on the lateral side. Nerve is, for my point of view, nerve is 1 kilometer away from your working field. It is in the approach, not in the field. So it is away. So you can see now 3D CT combination of the pictures, on table pictures. This is the split, and this is the articular surface, which is different. You can see everything in front of your eyes. You can elevate directly with a osteodome or a punch. Elevate it, pass 2K wires underneath the fragment, and you can see your wires going underneath the fragment through the fracture from your window, and they're exactly supporting it. And you can confirm under IIT, see the elevation, complete elevation of the condyle is achieved, and you can see the wires quite posteriorly without a danger to the vessel or nerve. Everything is in front of your eyes. Now you put a elevate in the gap filler, and you put a 3.5 buttress plate. and that's the plating, and that's the closure. Straightforward approach, and this is a 4 months follow-up with full function. Another case, we will see. This again a post-rotator condyle. It's a big, more comminuted fracture, displacement more posteriorly, and anteriorly there is no fracture. So again the same approach. I am revising it again. This is the poppeta crease. I is the incision, N is the nerve, F is the fibula head, and P is poppeta crease. You can see in the first upper picture, and I have surface marked the nerve. The nerve should be here probably. You always try when you are doing the initial cases. So you will know that you are encountering the nerve here. Cut skin subcutaneous tissue and identify the nerve like this in the fascia. Then separate. This is the lateral gastrocnemius, and my artery is pointing towards the nerve. I have dissected the fascia from distal to proximal, and now is separated. I have to just separate and identify the nerve. That's all. Then we don't have to handle the nerve. No retractor on that side. Retract everything on medial side. So retracted, and you can see proximally the head of the fibula, which is white, and you can see the anterior artery. Arrow. Once you cut the fibers of the, you cut the fibers of soleus muscle from the head of the fibula. Medially, in the medial part of the fibula, you can encounter the horizontal structure going. Anteriorly, on the intracranial membrane, that is the anterior artery. Okay, don't retract it. Don't put any right angle or a Homan retractor or a spike. Just put spike medially on that side, and you can just run your periosteum underneath the artery, and you will get a space for the plate. So I have got a space for the plate. This is white in the left side. Second picture, white is the depressed arterial surface I can see in front of my eyes. I elevated, put a K-wire, use the filler, and a rebuttress plate. You can see the pre-op and post-op pictures. Perfect elevation and reduction could be achieved from this direct approach. So direct approach is better for treatment of post-rotator condyle. It changes outcome in form of beta reduction, fixation, and functional outcome. Anatomy reduction of the articular fracture definitely improves the outcome. This is a road which is less traveled. But if you hang around, you can definitely reach to the destination without any fear. I cannot teach anybody anything. I can only make them think. Thank you very much.
Thank you, Jignesh Bhai. You always make it look so simple that I always feel that I should start doing it from tomorrow. Thanks a lot.
Thanks a lot. Thanks a lot, Chetan Bhai, for nice comment.
Next, we invite a very senior faculty from Germany, Dr. Akhil Verheerden, who is a senior consultant at hospital at Leer and the head of orthopedic surgery there. He has been a pillar of this course, chaired it many times in the past. Akhil, welcome to the Pune, our first virtual Pune trauma course. We would have liked to have you in person here, but for obvious reasons. So he's going to talk to us on complex tibial nailings. Over to you, Akhil.
Hello, Chetan. So nice to hear you whenever I'm not able to really, touch you. Hopefully we can have a nice communication anyway.
Thank you.
So it's the first time I do it like that. I'm sitting here in my flat in the city of Freiburg on the Black Forest area. So it's still day, as you see. I think probably in India it's night already.
Night.
Okay. So from my side, I'm ready to start.
Just share your screen and start.
Yeah. So I'll do that. Okay.
That's right.
Okay, but now you see a few things.
Yes, we can see your slides
You
now.
can see the presentation probably because on my screen it looks a little strange.
No, we can see it very clear.
Okay, so nice. So what you asked me was talking about complex tibial fractures. I just got a case 10 days back, which I would like to share with you, because in this case, many problems we have to face when we talk about complex tibial fractures are addressed in this case here. You see, it's at least a 3-plane fracture. We see here on the malleolus is one fracture, then the segmental shaft fracture. We also see that on the other plane. if anybody looks very close, what you also can see, there is also an Hoffer fracture on the lateral condyle of the distal femur. But this is not our issue. We're talking about the tibia right now. So the patient came, he had an accident, a working accident. He was just pressed in between a vehicle and a container. It was a monotrauma, though only his left leg was injured, nothing else. So I decided to go for primary fixation in the evening. So when we think about, I think basic fixation, most people would do here is just put an external fixator first. Yeah. In this case, because the soft tissue has been pretty good, so the accident was maybe just 3 hours ago, so I decided to go for primary nailing in this case. When we look at the X-ray, we know this proximal type of tibia fractures, they are also very sensitive to malalignment. So what's really crucial to get the entry point of the nail on the right way. When I do a midshaft fracture or even a distal tibial fracture, I always make my incision on the medial side of the ligamentum patellae. Usually I don't do a patella split. I think in nearly all of the cases you can preserve, not hurt, the ligamentum patellae. In midshaft and distal, I go medial side. But in this case here, when you have a proximal tibial fracture, you should go on the lateral side. Which you see over here, this is an intraoperative. You see, this is my rod. Here is the entry point. And what you see over here, I put a second rod just working as a polar screw, just to force the nail to go more to the central side, not to end up over here. This is another rod I put in preliminary just to be sure that the nail's gonna work the right direction. Now you see the nail has been inserted already. Just to get this together, I put a reduction clamp due to two percutaneous incisions. And as you see over here, I did it, this is a depth gauge. I drilled a hole here already to put in a polar screw here, just to make sure that the proximal alignment is fine. And as you see on the next X-ray here, the polar screw is inserted. So that's how it looks on the proximal aspect. Again, what's also very important, the entry point has to be very high. You cannot go up to down to the tuberosity. You really have to start very high. The entry point is over here. Otherwise, it goes into recurvation and you don't get good alignment in the sagittal plane. Here you see, this is just the malleolus medialis, which is not a big issue. Here you see the fixing, and here also the Hoffer fracture has been fixed with 3 cannulated screws. This is the intraoperative CT scan, and here's another here in the CT reconstruction you can see. And again, what's important, it's better always to compress a little more. Yeah, don't leave gaps over here. Better to shorten the lower leg maybe for 1 centimeter instead of getting a non-union in the proximal fracture site. So you see a little compression over here and a good contact also in the midshaft side. So this hopefully will end up in a good healing. I cannot say anything about healing because the surgery is just 10 days ago, but till now the patient is fine. This is a post-op X-ray we just did 3 days ago with a nail in both planes, and also the Hoffer fracture addressed with the 2 screws. So when we're talking about complex tibial fractures, there are two main issues. One is a soft tissue management, which is really important, but I don't talk about this here because otherwise the talk gonna be too long. What I want to focus on is the actual alignment in the proximal and distal fracture locations, just to get that proper. Delayed and non-unions at one of the fracture site is also an issue, but I don't talk about that too, because as I said, we don't have that much time. I looked at the literature and I was really a little astonished seeing that since 10, 20 years, really not much has happened in terms of studies. And the problem is, it's really hard to randomize complex fractures because one, they are rare, especially in Germany. I think in India, they are still much more common. But anyway, to make a real good study on that, it's nearly impossible. That's the main reason because literature is still pretty poor in this type of injuries. What they find out here in this meta-analysis in injury is McMahon did that. They saw intramedullary nailing as the fastest time to fracture union. However, there are concerns regarding an increased deep infection rate in open segmental tibial fractures, but especially concerning post-operative deformities, they don't really have data you can talk about. As I told you, usually this is a medial site. This is for midshaft and distal fractures. For the proximal fracture, just makes the incision more on the lateral side. Your alignment will be better. This is just a comminuted fracture of the proximal third of the tibia. And here again, you see entry point, a little more lateral. And what's also very important, use a nail which has this at least 3 interlocking bolts, and these oblique bolts are provide a much better stability because the distance in the bone is much longer in them. So use those kind of nails which are also available in India. And here you see the post-op after 3 months, very good callus formation and a nice actual reconstruction. So one thing I want to put your attention on in proximal fracture, this is over here. You see, this is another case. It is a 6 months post-op, and many people are afraid because there is still this gap on the anterior side, which is in most of the cases you find. But don't care about that as long as there is a good callus formation on the posterior side. This takes a long time to heal, but it will heal. And also, as you see, this is after 6 months. No, I didn't get the slide after 2 years. After 2 years, this will be gone, and you can also remove the implant. So don't be afraid of this gap, which usually appears in the proximal type of tibial fractures. About the biomechanics, I told you already, this is a paper of Friedman in Clinical Orthopaedics, even in 1995, which nicely shows us the mechanics. And it also shows over here that you also have to be aware of the recurvation of the proximal fragment, which, as I told you already, you have to use an entry point in the sagittal view, which is really very high. That makes it easier. Blocking screws are very helpful. This kind of nail, I told you already. Another example of a segmental fracture, and here you see what can go wrong, because here the nail has to be inserted too much from the medial side. And as we see over here, in the next side, it has a slightly valgus deformity here. We wanted to, this is a very old case, I did it in Leipzig about 20 years ago, And I wanted to correct it after I saw it over here, when I saw the X-ray, because as I told you, the oblique bolts also should have been used, and entry point was wrong on this place, but the patient didn't want any correction, though it healed like that. Another case, I mainly show you the cases where something goes wrong, that you just see how to make it better. It's quite a simple proximal fracture. Again, entry point is too low, and you cannot really get the advantages of the long bolts if you use it of an entry point more higher. And as you see over here, after some weeks, it begins toggling. So you see the interlocking bolt is loosening over here. So in this case, what we did, we fixed it with an additional plate from the lateral side to get a good stability. And after that, the healing is uneventfully. You see a good callus formation and a good alignment on this side. Another complex fracture, again, two layers on the shaft combined with the tibial head over here. So in this case, we did it as it's mostly done. So we did an external fixator first, just waited till soft tissues have recovered a little bit on one side. And on the other side, what's an aspect I think we should also always discuss about. These are fractures which should be done when the most experienced surgeon is available. Because when you do a nail in such a type of fracture and you're not really experienced in that, the mistakes you do never can be corrected. But if you use a fixator, most of the mistakes maybe a resident has done can be corrected in the definite surgery, maybe some days later. So here, external fixator has been placed. We also have this tibial head fracture. And what we did a nailing and fixed the lateral tibial head fracture, which was not really a difficult one, with buttress plating. Again, take care of the alignment, which is quite good here. This is after 3 months, and this is after 1 year. You see nice healing, good bony consolidation, and this is even after implant removal. Now talking about the distal fracture side. Basically, I don't like fracture tables for tibia fractures at all, but especially when you have distal ones, I don't use a fracture table because you can more easily manipulate. Usually I fix the fibula first, and there is only one chance to place a nail in a short distal fragment. So we have to be really aware of that and take our time to do that. So just ream up to the fracture site first, and then place a rod in the distal fragment centrally in both planes. Control it with the image intensifier, and then distally ream up only to the intended nail diameter. Don't over-ream the distal fragment, but over-ream proximal to 1 and 1.5 millimeter. Then you get the best results. An example on that, a very distal fracture. And here you see in both planes, ream this part, put the rod, the reaming rod in there, and then ream it just to the diameter of the nail you intend to use. Then you have a perfect template for the nail where it goes in just by itself. And then you do the distal interlocking. At least 2 bolts are needed, 3 are even better, even if they come close to the fracture site to get the optimum stability there. And you see a nice functional outcome here after 6 months. But even if it's not made that great, as you see in this very old case, a very comminuted complex fracture of the distal tibia, first treated with external fixator. And here a nail was used. I don't really like the way it has been used. You see the nail is too short over here. It just put in, fibula is fixed with an LCP, and the comminution zone was just left. Nobody touched it. Yeah? And that was the advantage of this fracture. And you see after 3 months, there was a certain autodynamization. You see the static interlocking bolt has broken. That means there was a dynamization of maybe 8 millimeters. But finally, this ends up in a good bony healing. You see here the interlocking bolts have been removed, but the nail was still there. And after 2 years, even the nail have been removed. So in this case, it even worked. So the skills of the surgeon have not been that great. And this is a functional outcome of this patient, which you really cannot believe when you look at the primary X-ray. Another similar case, not that severe. And again, here, don't touch the fracture site. 2 interlocking bolts in both plane, good alignment, and after 2 years, a nice result. So let me conclude. The entry point for the proximal fractures has to be more lateral compared to midshaft and distal tibia fractures. The 4 interlocking options are very important in the distal one. Get a good stability, and a combination with lag screws and plating is possible. In the distal fractures, there is only one chance to place a nail, so really take care for that. Don't just ream without looking with a C-arm in both planes before you start reaming. Hollow screws can be helpful, and the cannulation of the nail is very helpful for the exact placement in the distal fragment. So, demanding surgery, is it to treat these complex tibial fractures, which requires the whole armamentarium of the nailing skills? Careful soft tissue management is important. And when using an external fixator first, always think when you place the shunt screws that they do not interfere with the interlocking bolts of the nail you intend to use later on. And combinations with lag screws and plating, especially on the proximal side of the tibia, is always possible. Thank you very much.
Thank you, Akhil. Amazing cases and great tips as usual. We really thank you for taking time for this course. There have been a few questions. One is, do you always remove your tibial nails after a few years?
Most in young patients, in the most cases, we do that. Mainly because one argument is that just people demand it. And on the other side, we think of maybe you have to go for a total knee in age of 60, 70 to remove a nail which has, especially a titanium nail, which is in for 20, 30 years or longer, is nearly impossible.
Difficult. Yeah.
So we just think of the future, just not just to have any options possible. Yeah? That's why in young patients, we usually remove the implants. In patients 60 plus, we think more, maybe if the joint looks good, maybe we leave it.
Second question was, when will you fix the fibula in a tibial fracture? So I guess in the lower third.
You mean when during surgery or in which cases?
No, in which cases? Indications for fixing the fibula.
I think in the distal fifth, I always do it. Otherwise, I check if there is, if the ankle is really stable, though it's not there's the membrana interossea is intact, then you can leave it. But I think in the fourth, fifth of the tibia, I always look also, sometimes it's nice to fix it because it's also a good indicator for rotation. Yeah? But it's not really needed. It depends on soft tissue, depends on the individual case.
And one question was, in proximal tibias, do you prefer suprapatellar entry or standard?
I prefer standard. I tried suprapatellar a few times. It also works, but I'm used to the standard. I prefer it. I think for the surgeon, if you are used to it, for the surgeon, it's more comfortable to use a suprapatellar approach because the leg is just flat on the table. You don't have to move that much. That's people tell me who likes the approach. I personally don't like it that much.
Any tips for isolated tibial fractures without a fibular fracture? Any tips for such fractures for reduction as well as fixation?
I think usually reduction is easier if the fibula is still in place. So maybe there is one issue about the intact fibula is when there is a certain comminution zone in the tibia, which might end up in a malunion or delayed union.
So do you do an osteotomy or you do something?
In those cases, sometimes an osteotomy is helpful, but I think I never did it in the first place. I did, I think, 2-3 osteotomies, very oblique, after 3 months when I see there is a problem in healing of the tibia, but I don't do it primary.
Okay. Thank you very much, Akhil. Any other questions, Atul?
For the fracture of upper end tibia, lateral condyle tibia, why not to use a multi-locking nail and only screws instead of having plate?
If you have a good bone quality, that's nice. That's also possible. I totally agree.
Thank you so much, Akhil, for joining us. Really appreciate it.
Yeah, thank you for the invitation. I really loved to see all of you and listen to your lectures. We have heard very nice lectures I've been following today. I will continue that. Thank you for your invitation, and hopefully we see us personally
next year.
One of the next years. Yeah.
All right. Thanks a lot.
Thank you.
So next, we move on to another complex topic, and that's the plafond. And I invite Dr. Brad Petrizzo, who is also the co-chair of this course. We heard him yesterday, and he's going to highlight and enlighten us on how to deal with the plafond.
Thank you very much. Akhil, that was a great talk.
Share it.
I was wondering if...
nice to see you, Brad.
Yeah, nice to see you too. And that was great. Do you mind stopping sharing your screen?
Yes, stop. Okay.
Yeah, that's right. Yeah.
It's fine like that.
Perfect. Thanks so much. Why won't it let me? Oh, there we go. Is that good?
Yes, we can see it.
So Chetan mentioned that the plafond was complex, but my task is to simplify it, I think. So we'll see how that goes. It's obviously one of those axially loading bad injuries. So in simplistic terms, we always have to think about the soft tissues and then obviously think about the fracture. And one of the things that I talk to people about who have these is they're not going to be the same, their ankle's not going to be the same, and there's significant risks of infection and complications. So from a first point, these are bad actors, people aren't going to be the same, and there's significant risks of infection and complications. And so people talk about the management of the soft tissues and how is that going on? So you come in with a fracture like this, And 15, 17 years ago, people would automatically get placed into a frame, period. And people were teaching that delayed fixation is the way to go, and everybody was getting framed. And when I first started, we were coming, just operating on people after a few weeks. And that data came from these couple of papers that were published in 1999, looking at a policy change of their units. And if you look at the number of patients that were in some of these articles, you know, these were massively practice changing things that were being supported, saying delay the treatment, put a frame on, and then you'll get better results. Well, it wasn't until 10 years later that the Vancouver group in Canada on the West Coast really had a look at this, and it was getting to the point where it was almost a medical legal issue or a standard of practice that you can't fix pilons early. And so Tim, who's now in Edinburgh, and the group in Vancouver looked at this, and they looked at early versus delayed surgery in their own cohorts and really didn't see the significant difference in decreases in infection rates that other people had seen. And then 5 years later, other people are starting to publish on this as well and agree, maybe it's okay to go in early. Maybe we do not always have to put a frame on. And so, and then data started coming out, well, what are the risk factors for infection? Well, if you look at these guys who looked at 500 and almost 20 fractures, open fracture overwhelmed everything. Open fractures and energy that goes into it are a risk of infection. The duration of the surgery, number two, and also some glucose levels. Is there metabolic reasons? Secondly, you know, when people start putting these frames on and then we start to put plates in that sometimes are 3 weeks down the road, you know, this is level 4 evidence, but is there an increased risk of infection after putting these frames on? And so the pendulum kind of starts to swing backwards. And I don't know if anybody has fixed a lot of these late. I tell you, I was not having a lot of fun doing it late. Yeah, it's easy to put the frame on. Now, these frames are now one-off uses for us and still cost upwards of $800 or $1,000 to put a frame on somebody and then come back and fix something 3 weeks later. It's not as easy as everybody says. And so we're actually getting to them much, much early. So from a plafond point of view, fix it early if you can is the argument. Now, obviously, if the soft tissues are crazy, if there's major fracture blisters, you may have to put a caveat on that. But if you can get to them really early, usually that's not the case, to be honest. And if they're open, fix them. But what are our goals if we do fix them? Well, simplistically speaking, restore the joint and attach it to the shaft in good alignment, just like every articular injury. Distal femurs, restore the joint and put it on the shaft in good alignment. So one of the things are, well, where do you put the plate? Well, there are two major things to consider when you're doing this. If you think about the morphology of the plafond injury, you usually have the anterolateral shaput, the posterior Volkmann, and the medial piece. And there's always varying degrees of comminution in the central portion. And some of that may dictate where you want to put the plate. For instance, if your major pieces are anterior and posterior, maybe that anterolateral plate is going to help you. Or if there's lots of central comminution, you want to think about what screw configuration is going to help you with that. But I would argue there's no good plate that catches all three of these for sure. And so I would argue that a better way to think about it is, how did this fail? And what forces do we want to counteract? So if you look at the fibula characteristics, and some of these slides are from my colleague Paul Duffy out in Calgary, you can have tension failure where the thing goes into varus. You can have compression failure of the fibula, like in this picture where there's valgus, and then you can have intact fibulas. And so if you look at the varus failure, where does the plate want to go? Well, just looking at it, you think, well, that plate wants to go on the medial side. You want to prevent medial displacement, use a medial approach with a medial buttress to prevent the varus. And maybe you need a small lateral or an anterolateral to do the shaput and do the fibula at the same time, if you're going to plate the fibula, which we're going to talk about later. But again, if you look at these injuries, yells back at you, I think I need a medial plate. And whatever plate you decide to use, locking, non-locking, etc., we don't have the evidence to suggest. We tend to use the locking plates, but mainly because they're pre-contoured, and it's actually just easier to use them because they're already contoured as you want. But I don't think there's any significant evidence to suggest that we're doing that. But all the companies are moving that way, or have moved that way. Again, here you go. So what about the compression failure? Well, it's the same thing. The ankles and valgus, you get compression failure here. And it just speaks to you to say, well, I think I need an anterolateral plate. I need some buttress on that force, and I need to pull it over. So the lateral buttress. So this may dictate a bit more of an anterolateral approach or lateral approach. And we'll get to the approaches in a bit of a second, but you want to get that anterolateral plate on there to prevent coming out laterally. And then maybe you just need a small medial approach to put on to buttress that medial fragment. I'll tell you, I've been moving away from using a lot of posterior plating for these for some reason, but again, it's something we can talk about. But the last thing you want to do is have a fracture that looks like that and an x-ray that looks like that. So that's why thinking that the way of failure helps to dictate where these plates are put on. And you'd rather have something that looks kind of like that. Small, nice little anterolateral plate, little medial buttress, fix the fibula if you need to. Again, you have a fracture that looks like that, and you want to have an x-ray that kind of looks like that, counteracting the forces that you think are going to affect your plating so to prevent failure. Now, in terms of a general fixation strategy, you can do whatever you think is best, but typically you're going to work back to front, posterolateral, posteromedial fragments, getting the central impaction sorted out, and then coming down and reducing any of the medial and anterolateral fracture fragments. Oftentimes provisional fixation is good. I'm not one, when I fix fractures, to provisionally fix a lot of stuff, but the plafond is one where I do hold things with K-wires and get lags and anatomic, stable fixation of the joint surface when you can. And then you can work to use minimal plate fixation techniques for the shaft should you need. And we've moved away a lot from locking screws up in the shaft, but I still will use locking screws down in the metaphysis. So I want to obtain anatomic rigid fixation, but then I'll add the locking screws metaphyseally, and then usually non-lockers up in the shaft. These intact fibula fractures, it seems everywhere, aren't the greatest with the plafond and can actually make things really difficult to reduce and to hold. And it's actually, these are ones you want to get at early. I've had some of these ones where the plafond doesn't look very bad, quote unquote, but the fibula is intact. And in actual fact, everything is shortened. And I've had these sent to me late, and dealing with that down the road is really difficult. So these are ones I would argue you want to get at early. Now, in terms of the approach, I would argue just pick a couple and stick to them. And for me, the workhorse approaches are the lateral anterolateral approach with a medial approach, or a direct anterior, maybe with a posterolateral approach if I need it. And those for me are the workhorse approaches. Through the anterolateral lateral approach, you can gain access to a large majority of the tibia. You can see it down here. Obviously, you want to avoid taking out your superficial perineal nerve, which comes around in there, but that's the only main structure to avoid. And you can do the whole anterior piece of the tibia from the lateral side. You can do anything you want from the fibula. And if you're going to do something medially, if you're going to make a small medial incision, then you can actually get at the posterior aspect of the tibia from the medial side, which is actually really easy. If I'm going to come down with an anterior approach, oftentimes there's a lot more central stuff I want to work on. And this is a direct anterior approach between tib ant and EHL, and just moving everything out of the way, neurovascular bundles protected and retracted laterally. But sometimes just getting at that central area is easier from this, because then you can book open your medial and anterolateral and then book them shut on and down. And then you can go to the posterolateral side. And if you need to tuck in and come underneath for any lateral stuff or posterior stuff you might need to do and address fibula if you need to. But you can easily put on a medial buttress plate with this approach. And sometimes you just put the plate underneath and then bring the skin over top and do some percutaneous stabs and get your screws in there. And you can easily dictate your shot put piece and get your anterolateral plate on. But you can see correlation between our CT and what we want to fix and in the OR. Don't forget to the femoral distractor. The femoral distractor can be your friend. When I first started, I used it a lot, actually. I'm moving away because I don't know, maybe just with experience, but the femoral distractor is a really nice tool, and it just allows things to kind of relax, and you're not so worried about positioning and people holding, etc. And you know, here's us just you know, using a medial approach with your femoral distractor. You can see it kind of just takes some of the pressure off. It's being distracted out. You've got everything where you want it. It's not in your way at all. It's a really functional tool for this. And you can put it where the X-fix pins are, etc. Should you need, or just put a Shands pin anywhere you want. I usually would put it in line if I'm going to do it. You can put it in the medial aspect of the talus, in between where tib ant and post tib come down. There's really nothing there, and you can just put your pin right there, and that allows for a nice central distraction of your talus instead of putting it in the calc or anywhere else. And again, you don't have to go with big incisions up the shaft. You can do the shaft component a little bit more minimally invasively. So really, you want to get a good articular reduction and rigid fixation. Now, what about the fibula, plated or not plated? Well, again, when everybody was framing these, for some reason, everybody felt, well, and they were taught, well, you got to plate the fibula, put the frame on, and then you can send it to someone who's going to fix the fracture. And that really became a problem for us when we were fixing a little bit later, because often the plates were put on, it wasn't quite reduced, and all that sort of stuff. And the arguments at that time were, well, you need to establish length and help stabilize it. And then I would get fractures that I would need to treat like this 2 or 3 weeks later, and it was never very easy. So we started telling people, look, if you're not going to treat the plafond fracture and you want to send it to someone who will, just don't do anything. Put a frame on, nothing fancy, and pull it out to length, and we'll deal with the rest. And standard medial frame, or an A-frame if you want, but a standard medial frame is fine. Just get it out to length. Now, what about when you fix things? There's increasing evidence, and Paul Turnett has really put this forward at the OTA and published in JOT, et cetera, that maybe you don't need to plate the fibula with everything. Maybe plating the fibula first and getting your length isn't what we need to do. And he didn't identify any significant differences in outcome or alignment. And the same with some further people who looked at that. Maybe we don't need to fix the fibula, and for me, I'm moving away from it. If I can get a good reduction and everything's fine. Now, like the tibia fracture that we just talked about, if the fibula fracture behaves like an ankle, or the syndesmosis is disrupted, or there's length issues, yes, we will consider fixing it. And I've actually moved in some cases, if the syndesmosis is intact, but there's a little bit of wiggle there, sometimes using, putting a flexible fixation up like a tool does with the tibia along the fibula might be good. But if the fibula behaves like an ankle or the syndesmosis is involved, I will be fixing it more commonly. Now, there's a debate over what construct. We've moved mainly to locking distal periarticular plates. They're well contoured, they're fine. But if you were to ask me, well, can you put a frame on it and all that sort of stuff? If you're an Elizarov person, by all means, if that's your thing, I'm not. I don't like it. I just tend not to use it. But if you look at a meta-analysis looking at it, there's really no big differences. And some people, especially it seems in the States in some places, they use it a lot. But I do not. For fresh fractures, essentially don't use it at all. And I don't see myself moving that way. So from a simple sense, remember they're bad injuries. 40% of people aren't back to work. These things take up to 2.5 years to heal. And there's arthritic changes that happen radiographically with time. And a lot of people don't get back to work. So if you want to fix it, I would argue fix it early. And for me, it's just get in there and get it done early. If you do an X fix and you want to delay it or you don't want to fix it, keep everything out of the zone of injury and just pull it out to length and don't do anything to the fibula. Place the plate according to the pattern of the injury, get the joint anatomic and just fix it to the shaft in the right alignment. And just pick your approach. Thanks.
Thank you, Brad. Great talk as usual and some great cases. Just a quick question. I see a lot of anterolateral plates and a fibular plate in your x-rays. Any tips on incisions?
Yeah, for the anterolateral plate and the fibular plate?
Yeah, together.
Yeah, I'll actually go laterally and kind of just use that anterolateral approach and just pull everything up. So if you want to fix the fibula and you want to use an anterolateral plate, you can essentially do it all from the same incision. Just beware of the superficial perineal nerve. So I'll just take it a little bit. I don't usually go anterior. You just have to extend your incision a little bit more and then come up over the top. Get a little curve at the bottom, and you can get at everything, to be honest with you.
Okay. The conventional teaching was to go posterolaterally first and then buttress the posterior fragment. You've been moving away from it. Any reason?
I personally have. I haven't seen that it's afforded me a lot of benefit. And to be honest, going medially and getting into there posteriorly is just as easy. And I've been using, if I want to go posteriorly, I've been using some medial approaches, and oftentimes you get spikes that come up. Do you know what I mean? Sometimes
Yes.
the back. So for me, and also I consider myself being sort of a, some may say efficient, but I kind of say lazy. I don't want to work on prone positions or lateral positions or changing positions in the OR, and getting that posterolateral plate on is a bit of a bun fight if you're not in the lateral position. And I just like fixing these fractures from the front. So if I need to do anything posteriorly, I'm often tucking around medially. And I don't think it's...
You posteriorize your medial incision?
Yeah.
Okay.
Yeah.
Atul, you wanted to ask something?
If you are a treating surgeon for a famous sports personality who had latest compound tibial fracture, what will be your protocol? I will not take the name.
If I was treating an orthopedic trauma surgeon treating a famous personality with a bad open tibia, segmental,
yeah,
my protocol would start immediately in the emergency room with antibiotics and an urgent quick washout, and take the patient urgently, unless I needed some further advanced imaging, for a layer by layer irrigation debridement and washout with saline, using any form of pulse or big low gravity flow, and washing it out. I would treat the fracture, which I believe was a segmental tibia fracture, with an intramedullary rod using a Keel's techniques, and getting an anatomic reduction. I would probably sprinkle some Vanco powder into the wound, because Vanco trial tells us that there may help with some of the gram-positive stuff. And I would keep him on antibiotics appropriately. And if he needed a tissue graft, if I could not close the wound, I would look to get this closed within 3 days, probably. Unless I'm at your center with a plastic surgeon who does free flaps, so I do it right after I nailed it.
Yeah.
Okay.
Thank you, Brad. Thank you so much for making it so quite simple, I would say. So next we move on to the ankle, and I invite Dr. Sushrut Babulkar from Nagpur to talk about specifically about the posterior malleolus. Dr. Sushrut is a senior surgeon from Nagpur. He's also the education officer for AO trauma for the last 3 years, and a great friend.
Thanks, Chetan. Thanks for involving. And thanks, Atul, as well. And Parag, good friend. It's been marvelous to see all of you together, and though not face to face, at least good interaction and good visuals on the so-called in-trend web-based meetings. So if we really look at posterior malleolus, these are the four varieties that we see commonly. And of course, CT scan has given and thrown a lot of light in terms of deciding what we should be doing with these fractures. Let's see first example, which is this kind of a avulsion injury, and we almost decided that we must not touch them. And all these years we have been not treating them surgically but conservatively, and this is one step up when there is some articular involvement there, again because it is involving less percentage of joint involvement. We decided all these years again to treat these fractures conservatively.
Sir, you
One
can switch
more.
on your video.
Sorry,
You can switch on your video. Your video is off.
my video is off. Can you see me now?
We can see your slide, Sushruth.
We can see your slide, but we cannot see your video. That is
Okay.
missing. Yeah, that is now it is visible.
Now you can see me. All right. Thank you. Thanks, Atul. One more step up is this kind of fracture, which was kind of involving more than, let's say, 25-30%, still not beyond 50%. And these kind of fractures were sitting on the fence. And the last variety, which was pretty obvious, that of course, this is a huge chunk of posterior malleolus and lateral malleolus involving 50% and more, some kind of a talar subluxation, and we would jump to operate on them. So this was what we all thought for last many years. What do we think about them now? If we look at posterior malleolar isolated fractures, they are more than 10% of all ankle fractures combined. And isolated posterior malleolus is not a very new entity. It has been there since long time. And we want to see the radiographs. We want to not only see the radiographs these days, but we also want to maybe do a CT scan of posterior malleolus today. So way back in 1822, Cooper described this, and then Henderson introduced the term trimalleolar ankle fractures, which if thrown in with comminution becomes a tibial platform fracture. Standard ankle plane X-ray we must take. Posterior talar subluxation can be identified on lateral radiograph, and this classical double contour sign will direct us towards involvement of posterior malleolus. Lateral, of course, will tell you talar subluxation and some amount of percentage of posterior malleolus involvement. But if we see the percentage of the articular surface, should we be talking in those terms today? Again, plain radiographs have poor reliability and accuracy, so we should throw in a CT scan the moment we think that articular surface is involved and there is some involvement of ankle and element of talar subluxation. So there is a CT-based classification now, which is extremely popular, which has been described by Yamaguchi, which tells us about the percentage involvement, the area involvement, and whether there is any talar subluxation or not. And it also classifies based on the amount of and shape of posterior malleolus. So how does it do it? Type 1 is a posterolateral oblique fracture as seen here. Type 2 is a transverse medial extension, being very common. And type 3 is a small shell type of fracture. If we move on and see the effect of this area onto weight-bearing surface, we will see that type 1 has 24% involvement of the weight-bearing area. Type 2 has almost 16% area involvement, and type 3 being a shell type of a fracture, more of a ligamentous injury posteriorly, has no direct effect on the weight bearing of talus and the weight transmitting from talus to the tibia. Then what does it affect? What we are more interested about is this area, which is extremely important, which shows the ligamentous attachment, and our interest is this posterior tibiofibular ligament, the inferior posterior tibiofibular ligament, which is attached to the medial portion of this posterior malleolus on the tibia. This is a very definitive area. This is a very small area as compared to the entire tibia, and amounts to only less than 50% of the posterior impression of tibia if we see bang on posteriorly. But the clinical decision of how to manage and what to manage depends on this area of ligamentous attachment on tibia. Internal fixation of posterior fragment comprises of 25 to 33% of the total tibial platform injuries. And this is a very interesting classification which divides into type 1, type 2, type 3, and type 4. And why is this classification more significant clinically to you and me is because of the incidence it is occurring and presenting to us, and the area and the number of articular surface involvement. So type 1 is a completely extra incisural fragment but intact fibular notch, so that's only 8%. Type 2 is the maximum, which is 52% of the clinical presentation, and what it does is intra-incisural posterolateral fragment involving the fibular notch this time, and that's the most common. Type 3 is intra-incisural posteromedial two-part fragment involving posterior part of fibular notch laterally and posterior colliculus medial malleolus. This is that typical flake fragment sign which I showed you, but 28%. And last of all is type 4, which is a large posterolateral triangular fragment carrying the posterior half of the fibular notch, and that's only 9%. Let's move on. Now, this is what we saw. If we put our type 1, type 2, type 3, and type 4 on this previous thought process of ours, what we see is this. So now, based on what we have decided earlier, only this probably demands conservative management. Rest all, because it is involving the lateral portion of tibia and thus involving the ligamentous attachment between tibia and fibula, thus rendering, if injured, talus unstable. If you treat even this small flake of fragment conservatively, later on, as soon as the weight bearing starts, talus will push this ligament out, causing early talar subluxation and thus early arthritic changes. And that's the importance of this CT scan and visualization of this posterior malleolus involvement. So irrespective of the amount of percentage of articular involvement, if you see location of the flake fragment in this area, you need to fix it and not think of conservative management. So that's the importance of this. There are type 2 variants. Type 2 is type 2. It's involving a portion of lateral portion of tibia with fibular notch. But depending on the area involved, it can be a flake, or it can be a tiny fragment with syndesmotic involvement, or it can be a more horizontal fracture, again involving the fibula, pushing it posteriorly further. Okay, so what do we do with such fractures? What we should do is we should try to push this ligamentous attached bony portion and fix it from posterior side. There is no way we can target this and try to put a antero-posterior screw. It will probably not hold it well. It is imperative that we see this and push this ligament into anatomical position Once you put this into anatomical position, as you see here, fibula will find its home into the notch back as it was. So now the recent concept is fixation of posterior malleolus irrespective of the size. Persistent fragment displacement otherwise will ensue. Regardless of size, we must restore the syndesmotic stability, which will lead to better outcome. We should try to avoid this antero-posterior screw and do a birbal ka khichdi. So this is not uh, good today. Don't do it. But what is the preferred way is do a posterior anterior fixation. Posterolateral approach is the main workhorse of posterior malleolus fracture, wherein the patient is prone. Both posterior malleolus and fibula can be addressed to this approach. We'll see how. Flexor hallucis longus is to be swept medially, and then we are bang on the posterior fragment, which is the area of interest. So that's image intensifier. You assess it. That's the nerve which we are looking at. Fibula there. That's your approach. Between tibia and fibula, you dissect out the nerve, and once you go push the flexor hallucis longus laterally, you are directly on the area of interest, which is the posterior malleolus. It's very easy to reduce it. Sometimes in comminuted fibula or comminuted lateral malleolus situation, it is better to temporarily fix the fibula to span it to length, so that automatically the posterior malleolus will fall into a position. If fibula is not comminuted, we can treat and reduce tibia first, posterior malleolus first, by such a temporary K-wire fixation. Confirm your position on image intensifier. That's how you have fixed it. Because fibula is not comminuted, we have chosen to fix the tibia first. Once the articular surface restoration is confirmed, you can proceed with fixation. Here I have chosen a reconstruction plate to fix the posterior malleolus. Once it is done, then one can go ahead with fixation. So that's an independent screw which is fixing the posterior malleolus, and a supporting buttress plate which will serve the purpose of buttressing, and that's how it will finally look. Once you do that, then you proceed with the same approach. Go on the lateral side, and fibula is flat on posterior aspect, and you can put a plate there and go ahead with fixation. If the fibula is comminuted, I prefer to temporarily put a plate there, not too many screws, because otherwise those screws might come in your way of fracture planes of posterior malleolus. So put as less of screws, use K wires, but this spanning fibula, especially in comminuted situation, to length will automatically make your posterior malleolus fall into place. That's how your final construct would look like. Then move on to medial malleolus in supine position, and independently percutaneously we have fixed the medial malleolus. So that's how we should be doing this particular approach, posterior lateral approach, which is the workhorse for posterior malleolus. Fragment should be mobilized from medial to lateral, proximal to distal, to preserve the posterior intertibiofibular ligament. That's the most important. We must see the ankle joint for any osteochondral debris, achieve anatomical reduction, fix the plate at the apex of the fracture. We can reduce and fix posterior malleolus before fibula if fibula is not too comminuted, and that's how ultimately it will look. So that's what you want to do, and put all these screws in convergent fashion there. If there is a lot of comminution, as I suggested, reduce and fix fibula first. We must pay attention to sural nerve. Avoid placing hardware in the posterior tibial tendon groove because the tendon get irritated. Syndesmotic stability must be checked using stress fluoroscopy and moving the ankle into maximum dorsiflexion and maximum palmar flexion. Post-operatively, I use cast or splint immobilization, non-weight bearing for 4 to 6 weeks, and then start toe touching. That's what I do. Ankle range of movement, depending on your fixation comfort, can be started as early as 2 weeks. if incisions are all right. So start weight bearing early, start mobilization of ankle early, and you will be a winner. Thank you very much for inviting me, Atul and Chetan. It was a great pleasure.
Thank you, Sushrut. Excellent presentation and lovely tips. Just a quick question. What was that plate which you showed as a buttress plate posteriorly?
Okay, actually, it's actually a mandible and skull plate which the plastic surgeons use. I trimmed it to fit on that posterior malleolus because I thought we want only buttressing. Once
Right.
the main fragment is put in by a screw, this will act as a good buttressing effect, preserving the blood supply, flush, so absolutely low profile.
So, as per you, antero-posterior fixation is out of the window now?
Yes, I think it's almost gone. Yes, absolutely.
Right.
But if it is reduced properly, just to neutralize from anterior to posterior, what is the problem?
You will be surprised, Atul, once you open posteriorly, you will see so many tiny fragments and ligamentous attachment, which you will very easily miss if you think you put anteroposterior screws and you have targeted those tiny fragments.
Sushrut, may I make a point here?
Absolutely,
Yes,
Mandeep,
sir.
The issue over here is it's like putting two screws on the medial condyle of the tibia. Unless you buttress it, it will ultimately give way. So when you put two screws from the front to the back and it was originally unstable, the time people got away was by putting syndesmotic screws to hold the fibula in place. And that is the time when they got away with it. So if you are not doing all that, you definitely need to buttress it. I mean, nobody thinks of putting just two screws in a medial condyle of the tibia. It will give way. So this is the problem. You need buttressing at the back.
I will take it further, Mandeep sir. The moment you put buttressing plate and you reconstruct posteriorly the ligament and the osteochondral fragment, the need for syndesmotic screw is almost zero.
Agree, but you still have to check for syndesmotic instability.
Absolutely.
Because it is not only posterior shift, it's also a rotational shift. So both of them need to be looked at. But Sushrut is right. There is data which says that if the ligaments are intact and if it's only a primarily posterior shift, you get the malleolus back, you may obviate the need for a syndesmotic screw.
Thank you, sir, for those inputs. Sushrut, you can stop sharing.
Thank you very much. Yes.
Thanks a lot. We move on to the foot, and I invite none other than Dr. Mandeep Dhillon, sir. I apologize for the delay, but then we've been all waiting to hear you on a very, very difficult topic, and that's the talus. Nobody needs Dr. Dhillon does not need any introduction in this country or anywhere else in the world for that matter. He's been the editor-in-chief of the AO Manual of Foot and Ankle Surgery. He's been the ex-president of Indian Orthopaedic Association. He's the head of orthopedic surgery at the Postgraduate Institute in Chandigarh. All of us have learned from him. He's the teacher of most of the teachers in orthopedics. So let's hear him on talus. Sir, unmute yourself.
Yeah, I have to unmute myself. That's what I did. Thank you, guys. I really don't think all that was due, but thank you for saying all those good things. Okay, I'm going to be giving you some tips to avoid problems in treating talus neck fractures. You know, we must all understand that talus neck fractures are uncommon. So the experience of most surgeons is somewhat limited. They are also high energy fractures. Can you see my video or no? Hello?
Yes, we can see your screen.
But not my video, huh?
No, not the video.
Why is that? I'll put my video again and start video. Even if you can't see it, it doesn't matter.
We can see it. We can see it now.
Okay, great. So the issue is that these are high energy injuries, and we must differentiate between what is a neck fracture and what is a body fracture. So today I'm going to be talking only about talus neck fractures. And the first tip I must give everyone, we must understand the injury. We should classify it properly, because without classifying it, you will not be able to really know what is happening. If you look at the talus, which is mostly covered with articular surfaces, the anatomy is unique. And you've got areas like the head, the neck, the body, and the processes. And today we'll focus on one of the more complex fractures due to the types of displacement, which is the fracture of the talus neck. Now, the first tip is we must understand it, because understanding the neck injury lets us know how much is the urgency of the intervention. It makes us think of the method of reduction and what exposure is needed. And it also gives us an idea of the implants which are required. So to understand it, we must understand that based on the degrees of displacement of the body of the talus, Hawkins has classified them into 3 stages, to which the 4th one was added by Canale. And the degree of displacement also determines the outcome due to the depth of the reduction of the blood supply in the proximal part of the bone. Even the Hawkins type 2 classification has now been subdivided into A and B, because the less displaced subtalar joint is easier to reduce, the type 2A, and the more displaced subtalar joint is more difficult to treat. And I'll show you some examples, and the outcomes are also not that good. So the second tip, to try and understand these fractures, we must get good quality x-rays. And I believe that a CT is also important to clarify the fracture patterns and show us the displacement. I'll show you examples as we go along. So we must define the injury patterns, because what we often underestimate is the degree of comminution. Many years ago, people didn't talk about it, but now we know that significant dorsomedial comminution of the neck could lead to malreduction. And we have also been able to identify significant comminution on the undersurface of the talus neck. And this has been seen more and more with the CT scans which we are getting. The second thing is, we often underestimate the rotations of the neck of the talus. We'll show you examples as we go along. Now, this is probably looks like an incomplete, undisplaced fracture. But if you look at the CT scan, you can see the opening up of the joint inferiorly. You can see the comminution of the undersurface of the talus, and all this could lead to potential instability and arthritis in the long run. So this is where CT scans help us to know what is happening over here. Another example, a type 2B displaced talus neck fracture in a young adult. A closed reduction was done, excellent relocation and reduction. And this was actually a POP cast applied in equinus, as has been advocated in past times, that if you put it in equinus, it will reduce very well. But look at what the CT shows us. It shows you a significant rotation of the distal fragment, the neck and the head fragment. And this would lead to significant varus and biomechanical problems as you walk along. So it's not as simple as you look. It has a 3-dimensional aspect to it, which you must understand before you start any treatment for the talus neck. Therefore, I feel that a CT scan is essential for talus, as you would do it for all intra-articular fractures. The third tip, huge debate about timing of intervention. Please realize that only some talus fractures are an absolute emergency for immediate fixation. I'm using the word immediate fixation. It is not an emergency for fixation, but, and this has been shown, that immediate operation is not essential. And why do we don't need it? Because the risk of avascular necrosis was thought to correlate with surgical delay. That is not the case anymore. So I am saying the emergency of treatment depends only in a small percentage of the cases. But remember, I am talking of fixation. If the joints are reduced, this has to be done as soon as possible. Most times, we can achieve this with a closed reduction. And then you can wait for the fixation for a senior surgeon to come, or while you get the CT, etc., etc. But if you have a fragment which is lying at the back, or you cannot reduce it, then you should open it immediately. Otherwise, you'll get skin necrosis, and these cases are the ones who would do badly in relation to avascular necrosis. So that's the fourth tip. Keep the reduction as a high priority, not the fixation. Tip number 5. Now, with an understanding of the fracture, you are ready to fix it. But remember, to fix it, we need to expose the fracture appropriately. So you have to plan the approach with care. And that means the standard of care today is 2 approaches. Any displaced talar neck fracture needs an anteromedial and an anterolateral approach to get a good evaluation of the varus and the rotation. This is the key point today, because unless you do these 2 approaches, from the medial side, you will understand the medial and dorsal comminution, which may need buttressing and grafting. And on the lateral side, which is the tension side, you will get a simple fracture from where you can put a compression screw through the shoulder of the neck. There's a small fragment there, and you will be able to get a good reduction and a good fixation. So that's why 2 approaches are important. The anteromedial is the workhorse. Everybody knows how to do the anteromedial approach, but the 2 key points are: we should not damage the deltoid, and we should avoid dissecting the dorsum of the neck of the talus, because we don't want to add to the surgical insult to the body proximally. The anterolateral is also an easy approach. You just go from the tip of the fibula to the metatarsal base, split the extensor muscle, and you can see not only the neck of the talus, but you get a good access to the subtalar joint. And from here, you could remove some loose bodies, or you can even look at any osteochondral fragments over here. So 2 approaches are the key. And to get a better exposure, do not hesitate to do a malleolar osteotomy, especially in type 3 fractures, where the body has gone to the back. And many of these will come with a medial malleolus fractures. If there is no medial malleolus fractures, do a properly structured, properly guided malleolar osteotomy, which when retracted will expose the whole proximal part of the body of the talus as well as the neck. So this is important, because unless you get a good exposure, you will not be able to reduce the fracture. So now tip number 6 is understand how to reduce the fracture, because this not only shortens surgical time, it reduces the surgeon's struggle and the iatrogenic tissue damage, which we could call. So there are many things which we need to understand in the reduction methods. And we'll start with our common talus fracture with comminution on the dorsomedial side. So you have to open up sometimes to get the length and the inclination of the talus correct. You may need to add in some bone graft over here, and then you can put in screws on the lateral side under compression. But the medial side may have to be held in place after an appropriate reduction. The next thing is displaced bodies in type 3 fracture. They are lying at the back. You'll have to pull the calcaneus distally to be able to derotate the posteriorly lying talus body. So you can either use a distractor, or you can use a Steinman pin in the calcaneus to pull it down. And I also add a pin into the dislocated talus to help manipulate it. And this is the way you use a distractor. You put a small distractor, you open up the joint, pull the calcaneus down, and then you'll be able to manipulate what you are doing in these cases. Tip number 6, remember the talus head along with the neck lying next to it has to be brought in the correct position. So what we do is you can insert a K-wire into the talus head as a joystick. And this, like example, is a Hawkins type 2A non-comminuted fracture, but look at the piece of the head. It's the neck and head is lying rotated and in a different position. So what you do is you put a K-wire and you achieve gently the frontal plane reduction. This is not enough, because as we've seen, there is an element of rotation. So the same K-wire can be used to get reduction in the malrotations also. And once you get it in place, you can temporarily fix it with K-wires and then go on to stabilize the fracture. And that brings me to tip number 7. You must understand what method of stabilization you want to use. We must also understand what are the implants required, because it's not K wires alone anymore. It's not just 1 or 2 screws anymore. It requires a judgment on our part on what to do, which where. Key point is rigid fixation. Because if you fix it rigidly, you can move the ankle joint early, but we have to be careful in rigid fixation because we don't want to compress and shorten the neck dorsomedially. Now, this is a Hawkins type 1 fracture. These are undisplaced, seen on all views, seen in CT scan. They can easily be fixed with percutaneous fixation, no problem. No K wires, because I would still recommend we fix them with screws which are cannulated and percutaneous, and you can be easily getting them mobilized, although I'm not talking about weight bearing in this. Now the type 2B without combination is also fairly easy to treat. You see, do a closed reduction. If it works, check your reduction with CT scans. If the CT scan like this is okay, you can go ahead with percutaneous fixation and you will get a good fixation and probably get a good outcome. The problem comes in the comminuted fractures. When there is a 2B type fracture with comminution, closed reduction will never be able to do everything for you. So here there are 2 major issues. Firstly, you have to plan and understand by looking at the 3D anatomy. Look at this: medial comminution, subtalar dislocation, lateral process fracture, and even lateral comminution. So this is a different kettle of fish. Here we have to look at so many things. We have to do a stepwise reduction. Remember, we first need to reduce the subtalar joint, and many times these are unstable. So once you've got it in place, I tend to hold them in place with a couple of K wires, because then I can move the foot and the neck fragment back onto this stable body held in place. So here we stabilize temporarily with 2 K wires, go on to the lateral side, open it up with a Jess fixator as a distractor, put multiple K wires, fix all the fragments. There was a fragment of the lateral process which required fixation, and we are getting these 2.4 millimeter mini fragment plates which we can put on the non-articular surface, then come onto the medial side through a medial approach and fix it with 2.7 millimeter cortical screws, which are not compression screws. And you will be able to get a good outcome in these cases. The worst ones are the Hawkins type 3. They are the most difficult to treat because you often struggle to get the neck, the body which is displaced to the back and rotated 90 degrees back into place. So look at the 3D anatomy of this case. The body is lying at the back. It's a posterior medial extrusion. I've seen people call it a Taylor extrusion also. It is rotated 90 degrees to the tibia, and invariably there is an element of crushing which leads to medial comminution. So this has to be reduced. You use a femoral distractor or you use a transverse pin through the calcaneus, create a space to reduce the body. I also use either a pin or a lever to reposition the body. And most times they will have a medial malleolus fracture. If they don't, it is wise to create a medial malleolus fracture. Then it becomes easy to reposition the body. And then you reduce it and you fix it adequately. You can use plates, you can use screws, whatever is required, you put over there in these fractures. Tip number 8. Most of us talk about comminution, but probably do not understand comminution. Generally, the lateral side is the non-comminuted slice. So here you can put compression screws. It's okay to compress from the shoulder of the talus. The medial side is generally comminuted. It's always comminuted on the dorsum as well on the medial side. So I would advise not to put compression screws on the medial side. This is a problem. I've taken out a couple of slides here, but when you compress it from this side, you get a varus and dorsiflexion malunion, and you'll be surprised at how common this is. Tip number 9, because we are seeing more and more cases with comminution, consider using plates. On the lateral side, you can use a tension band plate, which will hold it in position. And on the medial side, if required, you can use a bridge plate, which will again hold the length of the medial column of the talus. Now, this is an example which we did many years ago, where we used a mandibular plate. Now you get very good plates for the talus specifically, and here we put it in place and you fix it over there, making sure that you don't damage the articular surface. And this already had a comminuted medial malleolus, and this is what it looks like after the plating. He got avascular necrosis, but I have about a 9-year follow-up. He healed totally without any problems. Last tip: understand your ability to fix these fractures and make sure you have all available equipment. You should have the experience if you're looking at type 2Bs and type 3s. You should have all the equipment plus a good C-arm. And of course, you should work after a CT scan. And if in doubt, refer to a specialist in your area who would be able to do a good job. So folks, what have we learned? For a talus neck fracture, we have to plan, time, and understand the reduction. To get this properly, we have to expose it well. You may need an osteotomy, you may need many, many things. And always think of 2 incisions. 1 incision never really works. It's an old-fashioned school of thought. And we have to make sure that the neck and body are fixed together by rigid fixation. Not compression, but rigid fixation, because we don't want to compress medially if there is comminution. And that is why, if needed, we can always use plates. I thank you for your time.
Thank you, sir. That was a fabulous exposition of the talar fractures. Really, really good. Almost all aspects have been covered. There have been
Stop share. Okay.
A couple of questions. One of them is, how do you reduce the displaced talar neck fracture in emergency?
But it's always a close, depends. You see, type 2 comes fairly easy. Type 3, you can attempt a closed reduction. If you can't attempt a closed reduction, you must have them properly relaxed and anesthetized, and you can do a percutaneous pin into the type 3, rotate it and put it back. If it doesn't come back, then within a few hours you should operate it. If it comes back into place, then you can wait. Then you can wait till you have somebody senior, till you've got good quality CT scans, because the urgency is in the reduction of the joint, not in the fixation of the bone. And as I said, the principle is very simple. You have to understand what are the elements of you, because you will not be able to get an accurate reduction by closed methods. Only in the type 1 and the type 2A you may get an accurate reduction. Everything else, there is an element of rotation, there is an element of comminution, there is an element of, there are 2 joints involved. We forget that there are 2 joints involved. Both have to be accurately reduced, the ankle as well as the subtalar joint.
Right. So that brings me to the next question by a delegate. How do you assess rotational malalignment intraoperatively?
You can look at it. I mean, if you have a pre-op CT scan, you can look at it. But you see, even with comminution of the fracture line, you can see this. Now, remember what happens. Although this is not 100% true, a talus neck fracture is considered to be a dorsiflexion injury with a degree of eversion. So the distal fragment will always rotate in one direction, and the comminution will always be on the top and on the medial side. So once you've gotten it into length, then you have to see. And then when you try and align the 2 surfaces together, you will see that you can see the fracture gap when you're looking proximally. So you'll have to derotate it a bit. There is very limited data. Actually, I am guiding a PhD thesis by one of my assistant professors, Dr. Siddharth Sharma, where we are actually looking at measuring the inclinations, the versions, and the rotations of this, because we were surprised at the number of talus malunions we were getting. Can you imagine? We are getting about 16 to 20 malunions a year, and that too fixed. So that's a different kettle of fish.
Right, sir. Another question was, if you must plate, which side do you prefer?
No, it's like saying which out of forearm fractures, which one should I plate? you have to see the comminuted side. Okay, it is the, if you want to put it as a tension plate, it's usually put on the lateral side. But if you want to get the length of the medial side, then it's a bridge plate. The function of a plate comes into play only in the element of comminution. If there is no comminution, we really don't need a plate. You can put screws crossed one another, lateral side compressed, medial side positional screws. But if you want to plate it, you can plate it. On the lateral side, you have to bend the plate significantly, not to come onto the articular surface. On the medial side, you can put the plate, but keeping it short of the medial malleolus.
Right. Any change in your protocol for management in neglected talus fractures? That's from one of the delegates in Solapur.
Different kettle of fish, in the sense we really depends. I mean, ideally, all of them should be reduced. All of them should be fixed. The fear is of two things. One is avascular necrosis, which in itself is not a disaster, but avascular necrosis followed by collapse is a disaster. Okay, so if I leave a neglected fracture out there, I am leaving an unstable joint and the potentially avascular bone. If I reduce a talus fracture and it gets avascular later on, I have left at least maybe the subtalar joint may be good enough. I have left a good place for me to think of a Blair or an ankle fusion later on.
Fusion, yeah.
We reduce them, even if they come late.
Right. Thank you. So that answers all the questions, and thank you so much for your patience, your time. Really appreciate that. So next we move on to the last talk of today, and that's last but not the least, a very important talk on minimally invasive fixations of the calcaneum. I invite Dr. Sampath Dumre Patil from Pune,
Good evening.
Foot and ankle surgeon, to show us how to do minimally invasive calcaneal fixations.
Good evening, sir.
I really appreciate more than hundreds of delegates who are still sustaining and eager to hear to you, Sampath.
Thank you, sir. Am I audible clearly, sir?
Yes, yes, you are.
And are you able to see my screen, sir?
Yes, we can see your screen.
So I'm going to share a video of minimally invasive, that is sinus tarsi approach. And this is a fracture which is joint depression type. Here the facet has gone really down. And let us see how do we do it by sinus tarsi approach. Now we have to assess this fracture on all the views: axial view, the Broaden's view, lateral view, and also by CT scan. When we are studying CT scan, we should study again all views like sagittal, coronal, and axial view. But most important is coronal view, where we are going to see the facet of calcaneum at the widest part of facet of the talus. Now, if I yes, so this is axial view, this is CT scan, and look at this. This facet is absolutely going down, absolutely 90-degree down. But along with that, we have to also see axial alignment, heel height, width. Patient is in lateral position, CM from the front, surgeon standing behind. And this is how we are going to see the views. I'm going to stop this video here just to say that surgeon is standing here, CM from opposite side. And look at this. If you make it lateral, then it is lateral view. And if you make it externally rotated and angulate CM 30 to 40 degree, then you can see a good axial view and Broaden's view. To avoid irradiating your hands, try to use a sterile bandage here. This person should pull your forefoot with sterile bandage so that you don't put your hand over here while taking axial and Broaden's view. just before painting and draping, see that you try out axial and Broaden's view, and then only do painting draping, because so many times at the end of the bed or that table, there is a metal strip which usually superimpose. So you know your table and you do it beforehand, the position of patient, so that good axial and Broaden's views are seen. And then take this approach, lateral position. This is fibula and this is fourth metatarsal base. So an incision is taken from tip of fibula to the base of the fourth metatarsal. Now this is sinus tarsi incision. After elevating tourniquet, we are taking this incision, and only thing is, like any calcaneum case, we have to respect soft tissues. Wrinkles are there, but as compared to lateral extensile approach, we can go a little early. Be aware of branches of sural nerve here. Go sharp, but if you see them, just now again, I'm going to stop this video here. Now, if you see the nerve protected, but don't do the dissection by mosquito and undermine the edges. Do layer by layer, but sharp dissection. And when you go little slow here, because peroneal tendons are going to come obliquely here, and it is easy to nick the peroneal tendons because they are running obliquely. So go slowly till you visualize peroneal tendons, and once you visualize and retract, then go on cutting the structures. And next structure is calcaneofibular ligament. Now, to cut the calcaneofibular ligament, have a sheet underneath the medial malleolus so that you can invert the ankle. Once you invert ankle, you can stretch calcaneofibular ligament and you can cut it. Mind well, unless you cut that calcaneofibular ligament, you will not be able to open the joint and see the facet. So see how we are going to do it. Now I'm retracting peroneal tendons, and see this. This is a big calcaneofibular ligament. It's big structure, almost to the tune of 1 centimeter. But before that, double confirm that you are retracting peroneal tendons, and you have to cut this calcaneofibular ligament. Then only you will be able to open that subtalar joint, and you can open that facet. Now, this calcaneofibular ligament is cut by inverting the foot so that the ligament is stretched. Now see this. This is now the facet for the talus, and there should have been the calcaneum facet, posterior facet of calcaneum, but it has gone down 90 degrees like this. Now, our job is to recreate this particular angle and match the posterior facet of calcaneum to the posterior facet of talus. But before that, mind well, you have to put one K-wire, thick K-wire or Steinmann pin from lateral to medial in calcaneum, give traction, achieve the height, correct varus or valgus angulation, and then go for this facet reduction. Now, see this. To achieve this facet reduction, what I am doing is I am putting this osteotome, or you can take this homons. First, homons should be directed towards you, that means laterally, then turn inside, go beneath the facet, and then elevate it. So why I prefer homons? Because it is non-traumatic. So I'm repeating. Put it first towards you, that is laterally, then go beyond posterior facet of talus and make it 180 degree, and again then elevate it. So here I am putting the osteotome going between the lateral wall, because this was joint depression type, lateral wall and facet. Go a little bit more down and see this. Now I am elevating it, and look at this. Nice. See this. I'm putting the osteotome a little bit below the posterior facet of calcaneum. This is posterior facet of talus, and now I'm going to match it. This is very important. See this, almost done, almost done. See this now. This is absolutely parallel to the posterior facet of talus. And this is interarticular reduction. Once you achieve it, then hold it with K wire. I'm holding it with this temporary K wire. Then you are putting this important screw, which is from lateral to medial, little posterior to anterior, and little caudal to cephalad. I will repeat, lateral to medial, little posterior to anterior, and little caudal to cephalad. This screw is important, which will go towards the sustentaculum talus, and important to compress the facet with the sustentaculum talus. Now, this is K wire, and on which you can put 4 mm CC screw. If you want compression, then partially threaded screw. Protect your peroneal tendon all the time. Now this is drilling over the guide wire. I'm holding it with one temporary K wire and then inserting this screw. Of course, know your fracture anatomy well before you go for this fixation, because sometimes it is only tongue type fracture which can be elevated even simply by joysticking the posterior tuberosity. But this was joint depression. And look at this now. Now here, this is temporary K wire, and this is the screw in Broaden's view going across to the sustentaculum. So take Broaden's and axial views nicely. This is axial view. See, nice fixation around. And here you can put this plate also. This is 2.5 low profile plate. If you feel that even it needs buttressing for the anterior process for of calcaneum, then you can insert this plate through sinus tarsi approach, and then you can fix one screw in the anterior process, one screw in the posterior tuberosity. So even plating is possible through sinus tarsi approach. But remember well that you can see under CM and put these screws percutaneously, but always be aware of peroneal tendons and important structures over there. So this is how this case was fixed. A small 2.5 plate, one screw each, and a screw for the sustentaculum talus. Yeah, this is what I was talking about. Just to avoid irradiation, see that you are putting this sterile bandage, externally rotate it. Suppose he is sleeping in lateral position, externally rotate the foot and then dorsiflex to see axial, and internally rotate to see the Broaden's view. So these are important tips for seeing the view. And this is a good Broaden's view. This is how we see Broaden's view. This was all about the minimally invasive approach for the calcaneum fractures. Chetan sir, I'm happy to take any, if there are any questions.
Yes. Just one quick question for you.
Yes.
Should you be straight away going in for this? What are the fractures which you will advise this as a primary approach? Or should you be doing extensile first and then going in for this?
Yeah, definitely. That's a good question, because one should have a good understanding about fracture geometry. So for that, we should read our CT scan prior nicely. And also we have to have exposure of few cases of lateral extensile approach before you go for this minimally invasive approach for sure. So choose your patient cleverly. So I would keep in mind three things. One is patient, second is the fracture geometry itself, and third is surgeon factor. So unless you are well versed with some lateral extensile approach, I think directly going for sinus tarsi is not good, because through sinus tarsi we assessed the articular portion, but through other maneuvers, I did correct axial alignment. I did correct the height, width, and length. So we should be aware of all the manipulations to get those things right. It is not only the interarticular component, but it is all other parameters also contributing very nicely. You can imagine somebody who is put on varus. You cannot really make that posterior facet sit back there and do the job. It is like proximal humerus. If you have got varus reduction, you cannot make the gutta tuberosity sit over there. Similarly, here, all other parameters are also equally important, and keep it in mind that minimally invasive is adequate, but do consider all these other parameters also.
Right. So that's the message I wanted to give across, because you make it always sound so simple that everybody would start doing a minimally invasive calcaneum. But then, apart from the posterior facet, there are a lot of things that you need to take into consideration. And for that, I think orientation with a lateral extensile approach is mandatory before you embark on this approach. Anything to contribute, Brad?
Yeah, I totally agree. I think that is a huge point, and I say that to our trainees all the time, that they're missing out on that extensile approach, and you really get an idea for exactly what you need to fix. So I wholeheartedly agree. And on that point, I guess my question to you is, what's the best way, or how do you typically deal with those little pieces of lateral wall blowout when you're doing your MIS stuff? Because the perineals are there, we can really get into the joint nicely, but there's always that little bit of, how do you guys deal with that?
So
just punch in through the whatever approach you have, punch them in. Yeah. Yes, Sampath.
Yeah, that's a great point, because what is going to happen is once we get the length by lateral to medial wire, we pull them down along again with the same sterile bandage. Then what I do is, if this is a lateral wall, I'm going to put my Homans, that is forearm spike, in between the facet and lateral wall, going to reverse it, going to make it up. Once I get the facet up, the lateral wall will get the space to then get reduced. So that is how it is a jigsaw puzzle. If you are keeping soft tissues intact and each fragment is given its own place, then I think they should fall back down. If they are not falling back down, that means we should assess that I'm doing either varus correction incomplete, or I'm not getting this because I'm keeping all the soft tissue envelope intact. So that's why that Homan trick is very important. First, towards lateral wall, go inside and then elevate it, so that lateral wall remains there along with the soft tissue envelope and it falls back to the place. Because this lateral wall point is important. Otherwise, that broadening will irritate your peroneal tendons. And mind well that peroneal tubercle you are not disturbing. So this is an invalid point.
Great, thank you.
Thank you, Sampath. Anything, Dr. Mohit, you wish to add, or some concluding remarks for today? I think we have had a great day, a long day. I apologize for the delay. I really admire the tenacity of all the delegates, and I hope they've got good tips out of the long day today.
Yeah, I think the only thing I would say is, the biggest gain we have here is that, yes, we're a bit delayed, but it goes to the passion of each of the speakers, right? It goes to the fact that everyone here really wants to impart knowledge. So we take this as just a bonus opportunity. So whatever you came for, you got bonus footage today. So I think we should appreciate that. But once again, get some rest for those of you who are late into the evening, because we have yet another day to go. So it's exciting, and thank you all.
Thank you, all the faculty, all the panelists. I really thank you all from the bottom of my heart, and all the delegates as well. Tomorrow we have a even more interesting day or evening, I would say, with all plenary lectures on complications of trauma from all the stalwarts individually. So thank you all, and wish you all a good night and a good day ahead for all of you. Bye. Thank you, Ashok.